All right, everyone. Can y'all hear me okay? Good morning.
Yes, ma'am. Good morning.
How are y'all doing today? Y'all good?
Good morning.
All right. People are still trickling in. I was trying to give them time. Thank you. All right. I am Tracy Barker. I'm with Medicaid Program Support and Waiver. I oversee all y'all SD agencies with the performance agreement, and I oversee Ms. Kim with SRI as part of the contract. So you'll see me on emails too, and I can actually assist Ms. Kim if she is not available, but of course, Ms. Kim is your first contact. So we're here for the 2024 EPSDT Support Coordination Training. If y'all park at the Main Street Market, make sure that y'all validated y'all parking pass with the QR code. That's the only way we validate it now. If you park anywhere else, I got no control over that. So that's where you need to park. So hopefully the training will be our usual time. We made some changes. Hopefully it's a little bit easier for y'all to understand and comprehend, because we've been getting a lot of questions from Disability Rights of Louisiana, which is the advocacy center, regarding support coordination. So y'all have to stay on top of this program. I know the lawsuit's been out for 15, 20 years. It's still happening, guys. Y'all gotta do what's in that handbook and in these PowerPoints, okay? That handbook and PowerPoint is your Bible, okay? Refer to that first, then get with Kim, then get with the MCOs, then get with the PAL, but we've made everything easy for y'all to look at. Refer back to it, make sure, and we send you the up-to-date information. We'll send you out the ones after this training. I put this recording on my website, so y'all can refer back to it at any time. I'm trying to be candid with y'all, okay? Because we're getting so many complaints. If a participant requests something 1 month, something needs to be done by the next month. Do not let these cases are very overwhelming. You have to stay on top of this. SRI has the systems in place to give you ticklers, to remind you of that, okay? So I'm just laying that out here before we get that started. So, all right. And I will direct it to Kim.
All right, good morning, everyone. So I'm Kim Willems, and I'm with Statistical Resources, or SRI. My maiden name is Falling, so I'm the same person. All right. Okay. All right, so the purpose of today's training was to establish a uniform training module for the support coordination agency's designated trainer and supervisors to use in conjunction with the support coordination training handbook. So y'all will use this training module for all new support coordinators, supervisors, and trainers hired to serve the EPSDT targeted population as part of that 16 hours of orientation training that y'all do for new hires. And then also as part of the annual training, so 20 hours of annual training for existing. All right, if y'all have questions, just put it in the chat. Okay, and then as reference material for support coordinators and supervisors. All right, documents required for training. An electronic copy of the handbook and appendices was emailed out to everybody this week. We will be uploading that to the LDH website, so it will be easier for y'all to print. The appendices are mandatory forms that should help the support coordinator meet the needs of EPSDT beneficiaries. The PowerPoint presentation will be emailed to each agency after completion of the training, along with clarifications of any questions and answers that we receive. The handbook contains more detailed information than is provided in this presentation, and then current training materials can be found on this website. Okay, so we kind of revised the sections of the PowerPoint this year. So part one's going to be an overview. Part two, we're going to go over all the different services available to EPSDT beneficiaries. Part three is components of support coordination. Part four is coordination of services. And then part five is going to be support coordination agency requirements. Okay, so Louisiana Medicaid. The Medicaid program provides health coverage to eligible low-income adults, children, pregnant women, elderly adults, and people with disabilities. Currently in Louisiana, more than 2 million people are enrolled in Medicaid. The Louisiana Medicaid program is the state plan and operates within the Louisiana Department of Health according to federal laws and regulations. Medicaid is the payer of last resort, and Medicaid provides medically necessary services. So EPSDT stands for the Early and Periodic Screening, Diagnostic, and Treatment, and the EPSDT benefit provides comprehensive and preventative healthcare services for children under age 21 who are enrolled in Medicaid. EPSDT is the key to ensuring that children and adolescents receive appropriate preventative, dental, behavioral health, and specialty services. The goal is to ensure children in Medicaid have the opportunity to reach their full health potential, the right care to the right child at the right time in the right setting. So early, assessing and identifying problems early, periodic, checking children's health at periodic age-appropriate intervals, screening, providing physical, mental, developmental, dental, hearing, vision, and other screening tests to detect potential problems, diagnostic, performing diagnostic tests to follow up when a risk is identified, and treatment, control, correct, or reduce health problems found. Support coordination is a service provided by Louisiana Medicaid through performance agreements with agencies to serve Medicaid beneficiaries in one of several Medicaid programs such as EPSDT. EPSDT support coordination was established as a result of a lawsuit, Chisholm versus LDH, to provide support coordination to those individuals who have disabilities or chronic health conditions. So support coordinators link individuals to services and assist them with gaining access to needed medical, social, educational, and other services, identify additional services that might help individuals even before the family requests them, and eases the process of receiving services by helping to manage the care of the child and limit gaps between service providers. So a Chisholm class member is a beneficiary under the age of 21 who are eligible for the Louisiana Medicaid program and who are listed on the Developmental Disabilities Request for Services Registry. And then EPSDT targeted population support coordination eligibility, individuals on the registry or individuals for whom the service is determined medically necessary with documentation to substantiate that they meet the definition of special needs, and y'all can refer to Appendix P, the EPSDT support coordination fact sheet for that full definition of what special needs support coordination is, under the age of 21 and Medicaid eligible. How to access support coordination. Beneficiaries may elect to receive or discontinue EPSDT support coordination at any time. Discontinuing support coordination does not affect a beneficiary's eligibility to receive Medicaid services or their placement on the registry. Beneficiaries may request to resume support coordination services at any time by calling SRI at our toll-free number. They'll speak to Ms. Pat Carter and requesting support coordination for EPSDT. If an individual is not yet on the registry, we'll refer them to their local governing entity, and those contacts are on Appendix J1. If they receive a statement of denial from OCDD, they may still be eligible for EPSDT support coordination if they meet the definition of special needs. And again, y'all can refer to the EPSDT support coordination fact sheet for that definition. Okay, and then in Louisiana Medicaid, we have the fee-for-service Medicaid program. So this is traditional or legacy Medicaid for people who are not enrolled in a managed care organization for most of their health services. And then we have Medicaid Managed Care, or MCO for Managed Care Organization, which is the managed care system for physical health, specialized behavioral health, and non-emergency medical transportation services. It covers 1.82 million Louisianans, and Healthy Louisiana is the way most of Louisiana's Medicaid beneficiaries receive healthcare services. The Louisiana Department of Health contracts with MCOs that deliver healthcare through their provider networks. Some of these MCOs have a different network of doctors, hospitals, or other providers than traditional Medicaid. All MCOs cover the same core medical, behavioral health, and substance use treatment services, and then the plans also offer extra value-added Medicaid benefits and services that could differ between plans. We currently have 6 contracted MCOs working statewide: Aetna, AmeriHealth, Healthy Blue, Humana, Louisiana Healthcare, and United Healthcare. Medicaid eligibility and enrollment types. Determining eligibility for Medicaid is the responsibility of the Bureau of Health Services Financing. The Louisiana Medicaid Managed Care Program is comprised of mandatory and voluntary opt-in populations. LDH is responsible for determining eligibility for enrollment in the MCO. So we broadly refer to enrollees with either a P linkage, like P for physical health, or a B linkage for behavioral health. So when we're talking about P linkages, that's going to refer to enrollment in an MCO for physical health, specialized behavioral health, and transportation. And then if they're a B linkage, they're going to be enrolled in an MCO for their specialized behavioral health and their transportation, but their physical health services, they're going to receive through fee-for-service or legacy Medicaid.
Citizen class members are in that opt-out population. So if they are Chisholm, they can stay in legacy. But if they're no longer Chisholm and they get a statement of denial and a special needs, they are automatically transferred to the managed care organization. So that's just an FYI.
Okay, so we're going to talk.
And a waiver offer, excuse me.
Yes.
But they should continue, they should be able to continue with their legacy. But the waiver offer, sometimes it switches and we don't catch it. Let Kim know, and then she can let me know, and I can get with our member linkages here at Medicaid.
Okay, so we're going to talk about some of the mandatory and voluntary opt-in populations on the following slides, but this is not like all-inclusive. So for more information, you can call the Medicaid hotline toll-free Monday through Friday, 8 to 4:30 if you all have any additional questions. Okay, so Chisholm class members are part of that voluntary opt-in population. So remember that a Chisholm class member is a beneficiary that's under the age of 21, who's eligible for Louisiana Medicaid, and is listed on the Developmental Disabilities Request for Services Registry. So if they are a Chisholm class member, then they're part of voluntary opt-in, meaning that they can choose to have all of their health care through the MCO or only their specialized behavioral health and transportation. So your Chisholm class members are either going to be a P linkage if they opt in, or they're going to be a B linkage if they choose to stay in fee-for-service for their physical health services. And then, like Tracy was saying, if you receive a waiver offer, then that means that your name is removed from the registry, so you're no longer a Chisholm class member because you're not waiting for a waiver. So whenever we link them to waiver, they are flagged to stay in that B linkage while we wait for the waiver to be certified. So if y'all ever come across, like it happens once or twice a year, where someone receives a waiver offer and gets put into a P linkage, so meaning that they were with fee-for-service, they got their waiver offer, and they got put into an MCO. So if that ever happens, just let me know, and I can talk to member linkages and get it retroactively put back to a B. Okay, and then our other kind of special population is the Act 421 Children's Medicaid Option, or TEFRA. They are going to be part of the mandatory population, so those are all going to be P linkages. So they will receive all their Medicaid covered services through their MCO, so physical health, behavioral health, and transportation. And then Act 421 extends Medicaid eligibility to children covered through the Social Security Act and are families with income that is too high to qualify for Medicaid who could otherwise become Medicaid eligible if receiving extended care in an institutional setting, with the exception of children with dual coverage and Medicare and Medicaid enrollment in managed care is required for all participants in order to control the cost and enhance budget predictability. And like most of the families that I talked to are aware that they're Act 421. So if they're, just to clear up any confusion about that. All right, and then the other mandatory population is the coordinated system of care. The children who are deemed clinically and functionally eligible and participate in the CSOC program receive all Medicaid covered specialized behavioral health services through the CSOC contractor, Magellan of Louisiana. And the only exception is their psychiatric residential treatment, therapeutic group home, and substance use disorder residential services would still be covered by the MCO, but all other specialized behavioral health would be through Magellan. The MCOs will implement procedures to coordinate services it provides to the enrollee with the services the enrollee receives from the CSOC contractor, including sharing the results of any identification and assessment of that enrollee's needs to prevent duplication of those activities. So CSOC children will receive physical health and transportation through an MCO. Okay. So now we're going to talk about managed care. So choosing an MCO, the enrollment broker can provide choice counseling, which includes answering the beneficiary's questions and providing information in an unbiased manner on available MCOs and advising potential enrollees on what factors to consider when choosing among them. So the enrollment broker can be contacted at that 855 number. All right, and then things beneficiaries should consider before selecting an MCO: access to their current doctors and other healthcare providers. So not all doctors and providers are enrolled in all 6 of the managed care plans. So if they want to keep any of their providers, they should check to confirm that they are enrolled in the plan that they're going to choose. Support coordinators should assist Chisholm class members with determining if their current providers are in network. We're going to talk way more about providers and how to locate them, but the main website is myplan.healthy.la.gov. If you have a particular provider in mind, you can use that tool to search and it'll tell you which MCOs that provider is enrolled with. Access to prescription medications. It's important to check that you can access needed medications on the new plan. SCs should ensure that the medications that they are currently prescribed are covered by the MCO's formulary. A common preferred drug list can be found on the LDH website. It's important to check any medication not listed with each of the plans to see if it's covered. Each plan covers different drugs and has different prior authorization and step therapy procedures, and y'all can refer to the handbook, page 8, for links to each of the MCO's pharmacy benefits pages. And then the last thing is access to services. The MCO will be determining the services, amount, and duration of services to be received. The MCO has to provide the same amount, duration, and scope as fee-for-service, but they also offer value-added benefits, which are currently non-covered services by the Louisiana Medicaid State Plan. A complete listing of each MCO's value-added benefits can be found on the MCO comparison chart. And some examples are monetary rewards for completing health needs assessments, flu shots, wellness visits, vaccinations, GED test preparation, and gym memberships. And then the MCO comparison chart can be found online, or it's also included as Appendix S. And then when a Chisholm class member enrolls in an MCO, they will receive a welcome packet in the mail with their member handbook and or welcome letter. They'll also get a separate member ID card from their MCO. And then within 14 days, the MCO will call the new member. Support coordinators are responsible for informing Chisholm class members of the MCO's contractual obligation to ensure transition of care when enrolling in or switching MCOs. MCOs do not require service authorization for the continuation of medically necessary covered services of a new member transitioning into the MCO, regardless of whether services are provided by an in-network or out-of-network provider. However, the MCO may require prior authorization of services beyond 30 calendar days. So the MCO will honor any active PA up to 30 days or until the transition of care is complete, whether or not the previous PA is with an in-network or out-of-network provider. Okay, so enrollment and disenrollment in managed care, if they ever change plans, it's always going to be effective on the first day of the month. Any transfer request processed on or before the second to last business day of the month will be effective the first of the following month. So the cutoff date is any transfer request processed on the last business day of the month will not be effective until the first day of the second following month from the date of request. CHISM class members who have previously disenrolled from an MCO may re-enroll in an MCO only during the annual open enrollment period, which is going on right now. So open enrollment is October 15th through December 2nd. And then those changes will be effective January 1st. Members may request disenrollment if they are a new member. So CHISM class members have a 90-day disenrollment period from the effective date of the enrollment during which they can change MCOs for any reason. After 90 days, they will be locked into the MCO until the next annual open enrollment period unless they opt out of managed care for their physical health services or show cause for disenrollment from the MCO. Because remember, if you're a CHISM class member, you can go from a P linkage to a B linkage. And then some examples. So this example is in September of 2024, so the second to last business day of the month was September 27th. So if you want to change your health plan or dental plan, so your new plan starts the first of the following month, October 1st, you need to make the change before 6 p.m. on the second to last business day of the month. And if you make the change after September 27th, your new health plan or dental plan will not start until November 1st. And y'all can always go to myplan.healthy.la.gov and they have like this exact information every month. So you can let families know if they want to make changes. And then for more information on opting in and disenrolling, we have an appendix that y'all can give to families on voluntary opt-in to managed care for CHISM class members. And then you can always contact the Healthy Louisiana line at the 855 number. And then changing your MCO, they can go online and create an account. There's also a Healthy Louisiana mobile app that's free. You can call the Healthy Louisiana broker, and then during open enrollment, you can send the enrollment form via fax or mail. And then this is all of the MCO's member services lines. And then we also have a website that y'all can go to as well. And then y'all should familiarize yourselves with the member handbooks for each MCO. So those can all be found on LVH's website. And then also refer to the MCO manual and then the accompanying CHISM compliance guide. All right, so Medicaid eligibility verification. There's a Medicaid eligibility verification system, which is an electronic system used to verify Medicaid beneficiary eligibility and third-party liability. SCs are required to validate EPSDT beneficiaries' Medicaid eligibility through MEVs at the beginning of every month. MEVs will provide the SC with current information on the beneficiary's Medicaid coverage, including their MCO's information. If the beneficiary becomes ineligible for Medicaid, they are no longer eligible for support coordination and closure procedures shall be followed. If the beneficiary's Medicaid status is changed, including if their physical or behavioral coverage has changed, the SC must notify each provider of the change by the 5th of the month. If the provider does not accept the new coverage, the SC must notify the family and offer a freedom of choice list of providers in the new network. The support coordinator must update the physical and behavioral MCO agency and ELSIS as needed. So SRI gets a data file from Gainwell, and we populate most of the physical and behavioral MCO agency fields in ELSIS based on that file. If the fields are pink, that means that SRI is populating them and y'all are unable to edit it. If the fields are white, that means that they're not on the data file or y'all don't have a current PA for them. So y'all would be responsible for selecting the correct MCO. And then for physical MCO agency, leave that blank if they're in fee for service. And then for behavioral MCO agency, leave that blank if they're in CSOC. And then also make sure that y'all are checking the Medicaid identification number and ELSIS as needed. We do alert y'all if the Medicaid number does not match the PA that we issue, but please compare their Medicaid number from MEVS and the number entered into ELSIS. And then if we ever need to correct the Medicaid number on y'all's EPSDT support coordination PA, I just need a copy of the actual like printout from MEVS, and y'all can just email that to me. Okay, so once y'all determine who covers the beneficiary's physical health, specialized behavioral health, and transportation, then you can determine who will administer or cover specific Medicaid services for the beneficiary. Some Medicaid services, such as PCS, require prior authorization before they can be provided. Prior authorization is a requirement that a provider obtains approval from the beneficiary's health insurance before providing a particular service. Prior authorization is also known as pre-approval, and PA decisions are reached based on the medical necessity of the request. Okay, so if they are a P linkage or a CSOC child, their behavioral health or their physical health services, those PA requests are going to be acted on by the individual MCO. If they are B linkage, that means that they only have the MCO for specialized behavioral health. So their physical health services will be acted on by the fiscal intermediary, Gainwell Technologies, a company that contracts with the Louisiana Department of Health to perform this function. All right, and then specialized behavioral health, if you are a D linkage or a P linkage, those are all gonna have an MCO for their specialized behavioral health. And then I list some of the specialized behavioral health services that require a prior authorization. So community psychiatric support and treatment, psychosocial rehab, therapeutic group home, psychiatric residential treatment facilities, and substance use disorder residential services. All right, and then if you have a I will try to slow down a little bit. Okay, so CSOC children, they are going to have Magellan of Louisiana for their specialized behavioral health services. So Magellan of Louisiana is the contractor, and they will authorize specialized behavioral health for CSOC children. So even though some of those services may require prior authorization, the support coordinator is not required to do PA tracking on that. So we have a specific, like whenever I get to the service needs section, there's like a valid reason for not tracking. So you're just gonna mark that as a CSOC service, and y'all will not have to do PA tracking for that. And then, so Magellan's gonna cover the majority of the specialized behavioral health services, but if they need psychiatric residential treatment, therapeutic group home, or substance use disorder residential services, those PAs will still come from the MCO. All right, and then transportation services for all of our kids, they will have a managed care organization for their non-emergency medical transportation or non-emergency ambulance transportation, and no prior authorization is required for that. All right, and then ABA, all those PA requests are going to be acted on by the beneficiary's managed care organization. And then we have some carved out benefits. So these services will be paid by the Louisiana Department of Health on a fee-for-service basis for all beneficiaries. Okay. Okay, so all of these services listed are going to be covered by fee-for-service. So that's nursing facility for long-term care, early steps, anything that they're receiving through the school system that's included on their written plan of care, which could be an IEP, an IFSP, or a 504. All home and community-based waiver services, y'all's targeted case management, and then dental benefits are going to be through a prepaid ambulatory health plan, and we're going to talk about the dental plans later. And then CSOC services are going to be covered by Magellan. MCO members may obtain excluded services under the Louisiana State Plan or fee-for-service Medicaid. However, the MCO will not pay for these services. MCOs are responsible for informing members how to access services that are excluded from MCO and continue to be provided through fee-for-service. Okay, so any questions about part one?
And I will share the PowerPoint and all appendices with the LGE.
Okay, so part two, we're going to start with the goals of support coordination. Beneficiaries under the age of 21 with disabilities or chronic health conditions typically need more Medicaid services than their peers without disabilities or health concerns. Parents of youth with developmental disabilities are sometimes unaware of the services that may be available. Therefore, it's important for the support coordinator to be knowledgeable of these services and how to access them. As a support coordinator, it is your responsibility to make suggestions for these services. So don't wait for the family to request a service. If you see a need for one of these, inform the family and document their response. So I know y'all probably get aggravated with me, but that's a very common correction on the CPOCs. I just want to make sure that we have it documented. If it seems that there may be a need for a therapy, that we're documenting that that was offered and declined, offered and requested, offered and on hold. To try to use those, like just a concrete sentence, this was offered and it was declined, requested, or on hold. If the child may need additional services, but it is not clear, suggest appropriate evaluations to determine whether there is a need. If the family states they aren't interested in a service, accept that. However, feel free to remind the parent of the service again when the opportunity presents. Okay, so y'all will develop a full list of all the services a beneficiary needs, and then you'll help them get and coordinate these necessary services. Parents often do not understand aspects of the Medicaid system. And if y'all have a question, just put it in the chat.
Yeah, please don't raise your hand. We can't answer that right now. Put it in the chat, please. Thank you.
Therefore, one of the primary responsibilities of the support coordinator is to follow through with the request for services until the PA is either approved or denied based on medical necessity, and when approved, make sure the services are provided as authorized. The SC is responsible for coordinating all identified service needs, including Medicaid services that do not require a PA, paid and unpaid support, as well as non-Medicaid services. The SC must follow up to ensure services are received. Okay, so some of the services that are available, youth receiving targeted EPSDT support coordination are eligible to receive all medically necessary Medicaid services that are available to individuals under the age of 21. Specialized behavioral health services are administered under the authority of the Louisiana Department of Health in collaboration with the MCOs, as well as through the CSOC program contractor, Magellan of Louisiana, for members enrolled in CSOC. In addition, if they are placed on the registry, they may be eligible for services through the Louisiana Developmental Disability Services System, administered by OCDD through the local governing entities. Youth may be able to receive services through the school system or through early childhood education programs. All right, so the Medicaid EPSDT benefit, Section 1905, and the Social Security Act entitles eligible children under age 21 to Medicaid coverage of healthcare, diagnostic services, treatment, and other measures as described in Section 1905A that are medically necessary to correct or ameliorate defects and physical and mental illnesses and conditions, whether or not such services are covered under the state plan. EPSDT is more robust than the Medicaid benefit for adults, and all Medicaid coverable medically necessary services must be provided, even if the service is not available under the state plan to other Medicaid eligibles. Medical necessity is always determined on a case-by-case basis, and there are no arbitrary limitations on services allowed. So there are no fixed limits on the amounts of services beneficiaries under age 21 can receive. They are entitled to as many doctor visits and as many hours and amounts of any other service that's medically necessary for their individual conditions. Some Medicaid services must be prior authorized before the service can be provided. Medicaid offered services are more comprehensive than services offered through schools as part of a child's written plan of care. So that could be an individualized education plan, an IFSP, or a 504. Written plans of care only cover services that help with the child's education. Medicaid, outside of the written plan of care process, covers services needed to help any other aspect of a child's life as well. So for a listing of all the available Medicaid services, you can consult Appendix D, and then we have the Medicaid services chart is Appendix E. And then the handbook is going to provide more detailed information about specific services. But even if a service is not listed on the Medicaid services chart, it must still be covered if it is a service permitted by federal Medicaid law and is medically necessary to correct or ameliorate a physical or mental condition of a beneficiary who is under age 21. And the current Medicaid services chart can always be found on LDH's website. All right, so some of the services that are available to Medicaid eligible children, but that are not available to adults or are only available under certain circumstances are EPSDT support coordination, psych evals, medical, dental, vision, and hearing screenings, speech, occupational physical therapy, personal care services, skilled nursing, extended home health, pediatric day health care, dental care, hearing aids, eyeglasses, medical equipment, ABA, and any item or service that is medically necessary to correct or ameliorate health conditions of the child, regardless of whether an item or service is covered by the state plan, which includes a wide range of services not covered for individuals over the age of 21. Okay, so now we're going to go through all of the different Medicaid services that are available. So applied behavioral analysis. ABA therapy is a set of behavior treatments that work to increase useful or desired behaviors. ABA therapy teaches skills through the use of behavioral observation and reinforcement or prompting to teach each step of a targeted behavior. It increases language and communication skills to reduce problem behaviors, and it's based on reliable evidence of its success and alleviating autism and is not experimental. ABA applies scientific principles about learning and behavior to reduce behaviors that may be harmful or interfere with learning. ABA is available to Medicaid beneficiaries under the age of 21 who exhibit the presence of excesses and or deficits of behaviors that significantly interfere with home or community activities like aggression, self-injury, or elopement. They're diagnosed by a qualified healthcare professional with a condition for which ABA-based therapy is recognized as therapeutically appropriate, including autism spectrum disorder. They have a comprehensive diagnostic eval or CDE by a qualified healthcare professional, and they have a prescription for ABA-based therapy services ordered by a QHCP. If there is a recommendation in the CDE for ABA therapy, a separate prescription is not needed. To find an ABA provider. Yeah. We'll talk about wait lists, yeah.
So you're saying, is that 2 to 3 months later?
2 to 3 months. I found out of 20 providers, I found one, and they said, oh, 2 weeks. But then when we called back, we sent everything they wanted.
Yeah.
And when we called back, it's like, okay, it's been 2 weeks, and say, well, no, now it's 2 to 3 months.
But what you're telling me is actually better than what it has historically been, because it used to be 6 months to a year. So I'm happy to hear the 2 to 3 months.
Okay, so I'm not, oh, okay.
Yeah.
That's okay.
Yeah.
Yeah, and that's Renee Huff. She's our Chisholm contact and ABA, so she's your guru right there.
Yeah.
So,
We are going to talk about how to handle the PA tracking with waitlist placement. There's just some steps that we're going to take to confirm that they're actually on the wait list, and then you'll be able to untrack it while you wait for their name to come up.
yeah, and then one thing, if they are on the wait list for any services, when y'all contact the family once a month, contact that wait list provider to see if they're still on the wait list as there's openings. Because that's been a concern Disability Rights has brought to our attention as well. We had originally said quarterly, but it needs to be done monthly when y'all make the contacts and going over all the Medicaid services available for these beneficiaries.
Well, and the thing is, the world of ABA is constantly changing,
So,
and everything's constantly changing, so that monthly contact is important.
yeah, because our goal is for them to not have these services from us or any Medicaid services. We want them to be independent. So as soon as you find out about a service, get started on it, follow up, and we'll go more into detail.
So what Tracy's saying is we want them to access services as soon as possible so that the treatments work and they don't need
Need
as much
services.
services later on in their life.
Okay, so to find an ABA provider in your area, the first step would be to call the beneficiary's MCO. If they're not sure if they want ABA or they're not sure that it would meet their child's needs, you can contact the beneficiary's MCO and complete a referral for a CDE. The SC should assist the beneficiary in contacting the MCO to ask that they arrange for the CDE and should document this request in the service log. And for more information, you can contact LDH directly and refer to pages 18 through 19 of the handbook. And then we will talk about waitlist placement when we get to the PA tracking section.
They complete a referral, because when I called, they gave me the list of providers, they never asked me to do anything about it.
So sometimes when I say referral, I just mean like connecting the beneficiary to them. There's not like a particular form that we fill out.
So when you say referral, you're like, we've given you the freedom of choice list for ABA providers or any provider, and the family's made that choice. It's not a PAL referral. I can see how it's.
So sometimes, like when we say, like, if we refer them to a community service, that's not gonna go in like PA tracking, but you're connecting them to the service, and then you should always close the loop and make sure that they're actually getting what they requested, or, you know, picking another provider or another resource to help them meet that need. All right, transportation services, we've got non-emergency medical transportation, and that plays an essential role in enabling access to medically necessary services. NEMT provides transportation to and or from medical services covered by Medicaid when no other means of transportation is available. All beneficiaries will access this service through their MCO, and then the transportation phone numbers are found on Appendix C. Children under 17 must be accompanied by an attendant. The only exception to this rule is for all females, regardless of their age, seeking prenatal or postpartum care. If a child has to be transported, they're going to need a child passenger restraint system, just like they would in any other vehicle. And then with the exception of urgent transportation requests and discharges from inpatient facilities, arrangements should be made at least 48 hours in advance, so calling that transportation phone number. And the 48-hour minimum does not include non-business days. Transportation must be provided in all parishes and to all eligible beneficiaries. If there is a need for special arrangements, such as a lift-equipped transportation, the MCO must ensure that such arrangements are made promptly so the beneficiary can obtain the medical services they need. So y'all's role is to offer the service, provide it if requested, necessary assistance with scheduling appointments for and transportation to services, and this should be documented in the case record. And then we've got non-emergency ambulance transportation, which provides an eligible Medicaid beneficiary transportation by ground or air ambulance to and or from medical services covered by Medicaid when no other means of transportation is available and the beneficiary's condition is such that use of any other method of transportation is contraindicated or would make the beneficiary susceptible to injury. The nature of the trip is not an emergency, but the beneficiary requires the use of an ambulance. All NEAT trips will require a completed, valid certification of ambulance transportation form. The beneficiary's treating physician must certify on the CAT that the transportation is medically necessary and describe the medical condition which necessitates ambulance services. And there are separate phone numbers for the NEAT MCO contacts, and that's included in the handbook. And then we've got the gas reimbursement transportation program. Louisiana Medicaid will allow family members or friends of an eligible beneficiary to act as a gas reimbursement provider. So that's transporting the beneficiary to and or from Medicaid covered services and additional services approved by the beneficiary's assigned health plan. The program allows the individual participating as the gas reimbursement transportation provider to be reimbursed by the health plan based on the total mileage of each trip. In order to participate as a gas reimbursement provider, the individual must be 18 years of age or older and may not reside at the same address as the beneficiary, and the beneficiary may not act as a gas reimbursement provider and transport themselves to appointments. And if you have a family that's interested in that, you would call the transportation broker affiliated with the beneficiary's health plan, and those are the main numbers on Appendix C for transportation. All right, now we're going to cover behavioral health services. I did update this just yesterday, so these slides are going to look slightly different than y'all's, but I will send out an updated PowerPoint after the training. So the coordinated system of care was developed for Louisiana's youth with significant mental health disorders that are in or at imminent risk of out-of-home placement. CSOC offers an array of Medicaid state plan and home and community-based waiver services to youth in need of mental health and or substance use treatment who are deemed clinically and financially eligible. CSOC is an evidence-informed approach that enables youth to successfully live at home, stay in school, and reduce involvement in the child welfare and juvenile justice system. So CSOC might be right if the youth is 5 to 20 years old, has a mental health or co-occurring disorder, has a history with child welfare, juvenile justice, or trouble in school, and is at risk or in an out-of-home placement currently. So that could include in detention, homeless, psychiatric hospitalization, therapeutic group home. Partners play a very important role in the success of CSOC. CSOC intends to ensure that efforts on behalf of youth and families are integrated across systems. CSOC is a family-driven process, therefore referrals should be made with the parent or guardian's knowledge, consent, and participation. So to make a referral for CSOC, you can call Magellan directly at the referral line, or you can call the beneficiary's MCO. And again, the parent or guardian must be present or on the phone, or they can do it themselves. Magellan or the MCO will ask initial risk questions. If you called the MCO, they'll transfer the call to Magellan if the child meets the criteria, and then Magellan will conduct a brief child and adolescent needs assessment to establish preliminary eligibility. And then if based on that CANS assessment, they're eligible for CSOC, Magellan will refer the youth to a wraparound agency to ensure that a comprehensive assessment is completed, offer the youth and the family an opportunity to participate in CSOC, and begin forming the child and family team. Regardless of CSOC eligibility, they're managed care entity, so MCO if they're found ineligible for CSOC, or Magellan if they do go into CSOC, will ensure that the youth is referred to providers who can meet their needs. Youth enrolled in CSOC are assigned a worker called a wraparound facilitator. The youth and family will work with the facilitator to develop a plan of care with a team of people. The plan can include services and supports to meet their behavioral health needs, as well as other needed services and supports that affect their well-being. CSOC enrollees may receive these additional services: parent support and training, youth support and training, short-term respite, and independent living and skills building. If a beneficiary is part of CSOC, they can access their specialized behavioral health services by contacting Magellan. We've got their phone number. Okay, and then we've got a section on the specialized. All right, let me grab my handbook real quick. Okay, so go back. All right, so in the handbook on pages 23 and 24, we have a CSOC section that gives a brief description of the different services that are listed there through CSOC. So the short-term respite is designed to help meet the needs of the caregiver and the child. The respite provider cares for the youth or child in the child's home or a community setting to give the caregiver or guardian a break. Children or youth in CSOC can receive up to 300 hours of respite each year, and this service helps to reduce stressful situations, and respite may be planned or provided on an emergency basis. And then y'all should be working with the wraparound facilitator. So hopefully y'all can have meetings at this, like your quarterly visits at the same time as them. And if you're ever adding any specialized behavioral health services, make sure that you let the wraparound facilitator know so that y'all, are on the same page. Like y'all would update your plan of care, they would update theirs. And then they could include that provider in their child and family team meetings. All right, and then specialized behavioral health services that are available, they're broken down into a couple of sections. The first one is going to be your licensed practitioner and outpatient therapies. So that's going to include assessments, evaluations, and testing, individual, group, and family therapy, and then this list of evidence-based programs. So there's parent-child interaction therapy, PTSD treatment, trauma-focused cognitive behavioral therapy, eye movement desensitization, and processing therapy. And then they recently added dialectical behavior therapy. And then I will have an updated handbook for y'all that's going to go into more detail about what all these services are. And then for more information, y'all can visit the laevidencetopractice.com website and refer to the handbook. And then I just put a little note there that the specialized behavioral health services are either going to be accessed through the beneficiary's MCO if they're a P linkage or a B linkage. And then if they're in the CSOC waiver, this list is going to be accessed through Magellan. All right, and then the next group is the mental health rehabilitation services. So that includes your community psychiatric support and treatment, psychosocial rehab, and crisis intervention. And then all the ones with an asterisk are going to require a prior authorization from the MCO, and then CSOC youth are again going to access these services through Magellan. And then we've got mobile crisis response, crisis stabilization, and community brief crisis support. And then we've got outpatient substance use and the opioid treatment programs, and that's going to be accessed through the beneficiary's MCO or through Magellan if they're enrolled in CSOC. And then we've got the residential and hospital-based behavioral health treatment services. So that includes your therapeutic group home, psychiatric residential treatment facility, inpatient hospitalization, and residential substance use disorder services. And again, the one with the asterisks are going to be prior authorized by the beneficiary's MCO. And then even if they're in CSOC, they're still going to get their therapeutic group home, psychiatric residential treatment facility, and residential substance use disorder through the MCO. All right, and then we got a question about not all regions having providers with capacity to serve those. So we will add that to our questions and answers, and I'll get a response. All right, and then the next one is going to be school-based behavioral health services. Medicaid also funds behavioral health provided through schools or early childhood educational settings for children ages 3 to 21, such as regular kindergarten, public or private preschools, Head Start, child care facilities, or home instruction. So to be funded by Medicaid, they're going to be included in the child's written plan of care, which again is going to be an IEP, IFSP, or 504. Behavioral health services, treatment, and other measures to correct or ameliorate an identified mental health or substance use disorder diagnosis may be provided by licensed mental health practitioners or Louisiana certified school psychologists and counselors. All right, now we're going to jump into the Medicaid physical health services.
For the behavioral health services, is there any age requirements on any of them?
There are. So I think the question was
in behavioral health services, if there's any age requirements on them.
So I know that the Louisiana Evidence to Practice has a good handout on the different evidence-based programs. So like the parent-child interaction therapy, child-parent psychotherapy, and then there's like a preschool PTSD and a youth PTSD. So I know that that has like a good, easy-to-read graphic about the different ages. So I'd refer to that for your evidence-based programs. And
Is there a website? Or?
yes, yep, it's right here. The laevidencetopractice.com, and I'll find where that actual handout is that I'm talking about and send that out to y'all.
Thank you.
So that's going to be for the ones listed on page 25 under like these licensed practitioner outpatient therapies. So those do have some different age requirements for some of them. And then the other one is going to be multi-systemic therapy is for ages 0 through 20. And then the assertive community treatment is going to be ages 18 through 20. And then the opioid treatment programs like medication-assisted treatment is for ages 18 through 20. And I can ask if there's any other ones, but those are the ones that I'm aware of age requirement-wise. All right, so EPSDT screening services. Medicaid beneficiaries under the age of 21 are eligible for well-child visits known as screening services. So that's going to include a comprehensive health and developmental history, a physical exam, immunizations, lab tests, vision and hearing checks, developmental screening, autism screening, perinatal depression screening, dental screening, and health education. Screening services are available both on a regular basis and whenever additional health treatment or additional services are needed. So Louisiana uses the Bright Futures Periodicity Schedule developed by the American Academy of Pediatrics, and that can be found online. And then, so those are like all of your regular well-child visits that are recommended. And then in addition, an interperiodic screen can be obtained whenever one is requested by the parent or is recommended by a health, developmental, or educational professional, including a support coordinator, in order to determine the existence of certain physical or mental illnesses and determine a child's need for health treatment or additional services. And again, there are no limits on the number of visits that are medically necessary for the beneficiary's condition. Well-child visits, referred to as screening services, are the foundation of EPSDT coverage and are a crucial entry point for identifying concerns and conditions that require follow-up care. These visits are intended to be comprehensive and include age-appropriate screenings, referrals to diagnostic and specialty services, and referrals to establish ongoing dental, vision, and hearing care. Primary care providers are responsible for making appropriate referrals when needed based on the results of a screening. When detected early, medical conditions such as lead poisoning, sickle cell anemia, developmental delays, nutritional deficiencies, and behavioral disorders consistently result in successful outcomes and cost-effective treatment plans. Screening and diagnosis is the crucial link to necessary covered treatment. All right, so personal care services are provided by direct service workers and are defined as tasks that are medically necessary as they pertain to an EPSDT beneficiary's physical requirements when cognitive or physical limitations due to illness or injury necessitate assistance with their ADLs, which is going to include eating, toileting, bathing, bed mobility, transferring, dressing, locomotion, personal hygiene, and bladder or bowel requirements. Assistance is provided with meal preparation if the beneficiary is on a restricted diet that differs from the rest of the household members and no family member is preparing the meals. PCS does not include medical tasks such as medication administration, trach, feeding tube, or catheter requirements. If they need assistance with those type of medical needs, those would be covered through Medicaid's home health program. And then we have Appendix G, which gives you an EPSDT, PCS versus home health comparison chart that you can go over with families. And then that also has more detailed PCS rule information. PCS is not intended as a substitute for child care needs or to provide respite to the primary caregiver, and a parent or adult caregiver is not required to be in the home while services are being provided to children. PCS must be prior authorized by Gainwell Technologies if they have fee-for-service for their physical health or by the beneficiary's MCO. The provider must complete a social assessment form, a daily time schedule, and develop a plan of care. And then a practitioner must complete an EPSDT PCS Form 90 to prescribe or refer the service and sign the provider's plan of care. The number of hours approved is based on assistance with the personal care needs that are covered through the program. And again, there are no set limits to the number of hours a beneficiary can receive. The support coordinator should assure that the practitioner has all critical information before the services are prescribed. And all PA requests should include necessary documentation to support the medical necessity of the request. All right, and then we've got extended skilled nursing services, also known as extended home health. And that's going to provide nursing care to beneficiaries under the age of 21.
Hey, guys, if y'all have a question, please put that into the chat. We cannot get y'all to raise your hand, so please put that information into the chat. Thank you.
All right, and then extended skilled nursing must be prior authorized unless the visit is less than 3 hours per day. A prescription is needed from the authorizing healthcare provider stating the number of hours requested and a letter of medical necessity justifying the reason for extended skilled nursing services. And again, not limited.
That is inaccurate. It is based on medical necessity. So if the doctor says they need 8 hours a day, 7 days a week, based on their medical need, that is requested, but it has to be justified. So majority of the PCS is approved for 4 hours a day, 7 days a week. That's the majority, and we have seen some that have been approved for 1 hour and 30 minutes a day, 7 days a week. So if it's based on need, if they need more hours and it is approved, they can receive more than 28 hours a week. And also PCS, the immediate family cannot be the worker anymore. There's an informational bulletin that has gone out from Norma, the PAL over PCS. Immediate family members cannot be the worker. That exception was only allowed during COVID. That is not accurate anymore.
Okay, and then also in the new training materials, we added, I think it's the very last appendix, it's Appendix BB7, EPSDT PCS frequently asked questions. So that's a good guide for y'all. It can also be shared with waiver support coordinators. So it's got how is PCS authorized, how is a prior authorization obtained, what's the support coordinator's role, how to change PCS providers. And then question 5 is how many hours can a beneficiary receive? So it says there are no set limits. It's based on the beneficiary's need for assistance that are covered through the program. The beneficiary must be of an appropriate age to receive PCS, meaning that they're old enough to do the task themselves if they did not have a cognitive or physical limitation. And then hours may not be saved to be used later or in the excess of the number of hours specified to the approval letter. So if you are approved for 4 hours a day, that is the max that you can receive in a day. You can't not use 4 hours today and use 8 hours the next day because it's whatever they need is medically necessary for their personal care services. So it's not like
Yeah, it's not like waiver where you have that for the week. It's approved for 4 hours a day, 7 days a week. You cannot go 5 one day, 8 one day. That will not be allowed.
And then question 6 goes over, can a family member act as a direct service worker? Staff assigned shall not be a member of the beneficiary's immediate family. An immediate family is defined as father, mother, sister, brother, spouse, child, grandparent, in-law, or any individual acting as a parent or guardian of the recipient. PCS may be provided by a person of a degree of relationship to the beneficiary other than immediate family if the relative is not living in the beneficiary's home or if he or she is living in the home solely because his or her presence in the home is necessitated by the amount of care required by the beneficiary. And then we also have a question, can a beneficiary receive Children's Choice and EPSDT PCS? And the answer is yes. Children's Choice Waiver Family Support PCA and EPSDT PCS may be performed on the same date, but not at the same time. If the beneficiary is receiving home health, respite, or any other related service, the PCA provider cannot provide service at the same time as the other Medicaid covered service provider.
And I know a lot of y'all do waiver, support coordination, and have Children's Choice. The reason why it moved the Children's 12 age limit moved up to 21 is because they can access EPSDT services until age 21. So please, on your OCD planes of care, anybody that does it with your offices, please include the EPSDT services. And if y'all are not aware of the EPSDT services, refer to the Medicaid services chart. Give me a call. I don't mind helping you at all. But make sure any of your any individual under the age 21 is eligible for state plan services, and that needs to be reported in your plan of care. Uh-huh.
The families that are utilizing the self-direct,
Mm-hmm.
they don't want it, they need the extra hours, but they don't want to use it for life.
Huh? They should access state plan services before waiver. So, unfortunately, you can't make them take it, but as long as you have that you've told them about all the state plan services available and you have it documented, if anybody comes back, you're covered. Okay?
And then that informational bulletin Tracy was referring to is informational bulletin 23-5. So if you ever have a provider or family questioning who can be a worker, you can always refer them to that. You just Google it and it should come right up. And then we also updated the waiver fact sheets. I want to say that's Appendix I now. And it has a statement on each one about EPSDT PCS.
A quick question. You stated that state services should be accessed before waiver. So in cases of waiver where there's children's choice and they need more hours outside of the 20 that they're receiving, they cannot go backwards and do EPSDT? They can? So it'll be just an add-on.
Yeah, and it's just an add-on. What she was asking, if you have waiver, they make sure you access state plan services. That's in addition. Now, with the waivers, they can help with their homework. They can take them out in the community, where EPSDT PCS is just personal care needs, and you can't fluctuate it. But that can be in addition to the 20 hours that you're offered for Children's Choice. And that should be included in your OCD EPOC.
So basically, EPSDT just means you're Medicaid eligible and you're under 21. So even if you have waiver, you still have Medicaid, and if you're under 21, all these Medicaid services are available to you, and your waiver support coordinator should be helping coordinate those. A couple times a year, we'll get phone calls from waiver SCs saying that, like, they think that they need a support coordinator to get PCS.
No, and do not call SRI to request PCS services. We've gotten that email, and Kim sends it to me. Guys, refer to the Medicaid services chart. Contact, use the accesses, and if y'all just do EPSDT, share with y'all other SCs in waiver, okay? Y'all all a team. Y'all all here to help all these beneficiaries access services so they don't need them anymore, okay? So use your resources you have in your office. And we have it online. If y'all need something, contact Kim, contact me, contact Renee. We got you, all right?
And yeah, if you ever have a recommendation on what to add to one of these appendices, like if there's another frequently asked question that families have, just give me a call,
Now,
send me an email.
it is still, we're still in a lawsuit, so we can't make significant changes to anything with EPSDT without talking to plaintiff's counsel. So y'all can give us the recommendation, but unless they approve it, we can't make those changes. We had to send all our handbooks to get approved by them, and they commented. We did some changes. We don't. You got it, okay? But that's the thing. So we don't mind y'all giving me recommendations. Just said I can only do what I can. I'm not like waiver, okay?
All right, so skilled nursing, that's gonna be if it's less than 3 hours a day, that can be prescribed by a healthcare provider and obtained without prior authorization for beneficiaries 0 through 20. They're still gonna need that prescription, so it still has to be authorized by a healthcare provider. It still has to be provided by a home health provider. It just won't have that PA requirement. Then there's also home health aid services and rehabilitation services, which is your PT, OT, and ST. And that can be provided in the home, at an outpatient facility, an early intervention center or a rehab center, and at school. And all of the rehab services through home health require a PA. And then we've got pediatric day health care, which serves medically fragile individuals under the age of 21 who require close supervision. It's an alternative to healthcare choice or supplement to receiving in-home nursing care. So they would still be eligible for the extended home health service if that's medically necessary. It can be provided up to 7 days per week and up to 12 hours per day as documented in the plan of care. And it includes nursing care like trach, suctioning, medication management, G-tube, respiratory care. They can get their therapies there, assistance with activities of daily living, and transportation to and or from the PDHC facility. All right, and then we've got our therapies. So for Medicaid to cover them through the school, which is going to be ages 3 to 21, it's got to be part of the child's written plan of care, which again is IEP, IFST 504. And then for Medicaid to cover these services through an outpatient facility, in a rehab center, or through home health, they must be ordered by a physician and must be prior authorized by Gainwell Technologies for Medicaid fee-for-service. And then you're gonna have to check with the beneficiary's MCO to determine if that MCO requires a prior authorization. Some of them do have like what you call soft limits. So as long as they're not exceeding a certain number of visits, it may not require a prior authorization, but you can refer to the MCO's member handbook or call the MCO. So y'all need to explain to the individual that Medicaid will provide medically necessary therapies in addition to the therapies received at school. The SC will ask the beneficiary if they want to receive therapy outside of the school in addition to those that they receive in school. The beneficiary should be asked if they want to receive therapies during the school's summer break. And you'll help the family to determine the setting in which the child will receive the greatest benefit, and also help the family by making the appropriate referral and coordinating the days and times of the service with other services that they're receiving. And then medical equipment and supplies. Beneficiaries are entitled to any medically necessary medical supplies, equipment, and appliances needed to correct, improve, or assist in dealing with physical or mental conditions. This includes lifts and other devices to help the family deal with the child's circumstances, such as communication devices, and also some medically necessary dietary or nutritional assistance. Medical equipment and supplies must be prescribed by a physician and prior authorized by Gainwell Technologies for fee-for-service. And then you'll have to check with the MCO to determine if they require a PA. A lot of the MCOs, again, have a soft limit on incontinence supplies and Pediasure and stuff like that. So as long as they don't need an excessive amount of diapers, they wouldn't have to get a PA for that. Disposable incontinence supplies for children are available for ages 4 through 20, and based on medical necessity, diapers, pull-ups, and liners or guards may be covered. And then we've got the PA request forms and some of the physician forms available in Appendix BB1, so there is like a particular prescription to use for that.
And I'll just mention about diapers. You can start planning for diapers 6 months prior to their 4th birthday, and their PA can start on their 4th birthday. I did that when I was an SC. So you can, if you know this person will need diapers, when you get them as a 3-year-old, start planning that, get that provider, get it done so they can get the services at age 4.
So yeah, if y'all have a 3-year-old child and currently the family is providing the diapers, or they may be getting it through WIC. I am gonna still have y'all mark that as a service need, but we're just gonna check family if the family's paying for it out of pocket, or community if it's through WIC. And then that just reminds us that when they're about to turn 4, that you change it over to Medicaid. And then if it's fee for service, that's always gonna require a PA. If it's an MCO, then y'all will determine if they need a PA or not. All right, and then sometimes fee for service or the MCO, prior authorization unit may approve less expensive items that it believes will meet a beneficiary's needs, and if so, the notice of denial should identify the item. The beneficiary can accept the less costly item and still appeal the denial of the item originally requested. However, they must not dispose of, destroy, or damage beyond normal wear and tear the less expensive item while the appeal is pending. You consult with the beneficiary and the provider to see if the less costly item identified will work, and help the beneficiary decide whether to appeal for the item originally requested. The SC must explain appeal rights to the family and assist in the appeal if the beneficiary wants that help. And did y'all have a question?
I've had a couple instances over the past year where I have participants who, submit for Medicaid for their diapers. And, the providers will tell me that they're the primary insurance that they need to go through first. But then I've had parents tell me that their primary insurance does not cover incontinence supplies. So I just want to know what to do.
So I think, do you have to get a denial from?
So most of them don't, they probably need an EOB denying it,
Okay.
because, I mean, that's what we do for ABA. I haven't dealt with COV directly in years. But you probably, I'm guessing you need the EOB denying it. And then submit it to Medicaid for prior authorization with that EOB denial attached.
Okay.
Yeah, so the question was about for families that have private insurance, then when the SC submits a request for diapers to Medicaid, it gets denied, saying you need to seek it through the primary insurance first. So you would want to do that or get an explanation of benefits showing that it's not covered, and then submit that with the PA request.
Providers are not doing that because they say they're not getting paid, or when they get paid, they take their money back. Medicaid wants their money back. So the providers are not playing that game with the, if the person has a primary insurance, like Blue Cross Blue Shield or something, they don't pay it, they're not doing it. Because I've talked to providers.
Can y'all send us specific examples of that so we can work through them and figure out what's going on with the providers, the MCOs? That's what we need from y'all. Like, when you see things going on in the community that don't feel right, don't look right, you hit barriers, let us know, because we can fire off some emails.
You can send it to Kim,
And
Kim
then
and at least me.
Yeah.
And then I can get it to everybody in
Yeah, to the
LGA.
correct person.
Don't just sit there and struggle.
No. Same thing with behavioral health.
So y'all, there are a lot of services that Medicaid covers that private insurances do not. Now, Medicaid is the payer of last resort, so we're secondary to the primary insurances, but this is an issue across a lot of our EPSDT services, so we need to get this worked out.
Yeah.
So y'all need to send Tracy and Kim these examples, and I will help them resolve them.
Yeah.
And our contact information is on the last.
Yeah, our last slide.
Okay. And then we will get those added to the questions and answers as well.
Question, if families are only interested in diapers or interested in APA, not the PCS component, they can, as the poor coordination can help with everything outside of PCS as well.
You
It's not just PCS.
It's not just, whatever services are needed, necessary.
And even if
And
they don't
refer
want
to
any
that
Medicaid
Medicaid services chart. There's things that you might not know of. It's there. We recently updated it. There's a contact person's name on there. So like Norma, y'all might have spoken to Norma. She's over PCS. Miss Irma's over DME. There's different contacts here at Medicaid that can reach us. Or if you have any issues, reach out to me and we can direct it.
Y'all should be going over that Medicaid services chart.
Once a year. Yes, You should bring it to at least every quarterly visit. They should have access to it. Kim has the website up there. It's usually updated accordingly. I think the last one was September, so.
They don't have to access any one particular service. It's what the family needs and what is medically necessary.
Mm-hmm. Yep.
And
Whatever
they don't have to have support coordination to get PCS. It's not like waiver where you have to have.
No, because our service is optional. They don't have to have us. If they don't like you calling every month, just say, just want to let you know our services are optional. If you feel that we're not meeting your needs, we can close your case. And if they do call you back within 6 months, you can reopen it on your own. But if it's past 6 months, you have to call SRI. They would have to call SRI to reopen the case. Okay?
All right, and then this is a good slide to move to. Other Medicaid services not listed. So even if something is not on the Medicaid services chart, that they.
All right, y'all ready? Y'all got a lot of talking. I know, probably scared y'all, but we got to keep on going. We still got a lot of more information.
Okay, okay, so even if something is not on that Medicaid services chart or not on Appendix D, and the family feels like it's medically necessary, you can always call for fee-for-service, you would contact the Specialty Care Resource Line. And for the MCO, you would contact the beneficiary's MCO Member Services Line or their case manager at the MCO. So although a service may not be listed, if it is a service permitted by federal Medicaid law and is necessary to correct or ameliorate a physical or mental condition of a beneficiary who is under age 21, it must be covered. Persons under 21 are entitled to receive all equipment that is medically necessary, and this includes many items that are not covered for adults, and these services may be subject to the restrictions allowable under federal Medicaid law. All right, and then we've got our non-Medicaid services. So services available through your local governing entities would include flexible family fund, individual and family support, LGE support coordination, and y'all can refer to the handbook, and we've got the LGE directory as Appendix J1. Office of Behavioral Health has LGE Community Behavioral Health Services, CART, which is Child Adolescent Response Teams, and those services are covered on handbook page 35. And your Community Behavioral Health Services contact information for each region is going to be on Appendix J3. They're also eligible for services through the school system. Each school system in Louisiana has a child search coordinator who can arrange for evaluations of children to determine whether or not the child has a disability and requires special education services, and then any other community service that they're requesting. Home and community-based waivers for people with developmental disabilities. Most children currently receiving EPSDT support coordination are on the registry. So the waivers are the residential options waiver, the new opportunities waiver, children's choice waiver, and supports waiver. And then we've got the fact sheet as Appendix I. And then children's choice waiver opportunities shall be offered to individuals under the age of 21 who are on the registry and have the highest level of need. Services are capped at $20,650 per care plan year and can be used for medical care, home and vehicle modifications, caregiving assistance and support, and other specialty services. When the family chooses to accept children's choice, the child's name is taken off of the registry. So again, they would no longer be a Chisholm class member, but they should be staying in that B linkage. So again, if you have a family that accepts waiver and gets put into an MCO, just let me know. Youth who reach the age of 18 and want to work may choose to transition to a supports waiver as long as they remain eligible for waiver services. Youth who continue in the children's choice waiver beyond age 18 will age out when they reach their 21st birthday, and they will transition to the most appropriate waiver that meets their needs as long as they remain eligible. What happens at age 21? Because states are not required to cover optional Section 1905 benefits for adults, some services may no longer be available when beneficiaries turn 21, such as support coordination, EPSDT personal care services, extended home health, and incontinence supplies. If possible, the SC should identify alternatives during this critical time. The SC should be aware of available services and make arrangements to transition the beneficiary to receive all services he or she may need in order to continue to live in the most integrated setting appropriate. Planning should begin well in advance of the beneficiary's transition, and ELSIS will automatically prompt you to add transition as a service need if they're going to be 20 and a half years old during that plan of care year. Providers may need to be changed if the current provider only serves children. The SC should coordinate appointments, transfer medical records, and connect families with new healthcare providers. The SC should facilitate the development of a CPOC that outlines the transition process, including referrals to appropriate providers. So whenever y'all add transition as a service need, make sure that y'all are documenting the EPSDT transition strategy in the additional information section. And if you run out of room in any section, you can just put it in another section where you'll have room. So they should be informed of the change in Medicaid services for adults, long-term personal care services, OCDD services, how to obtain the services they now receive, link them to resources to receive those services, and then encourage them to obtain all exams, eyeglasses, durable medical equipment prior to aging out. So through OCDD, they may be eligible for extended family living, supported independent living, and vocational and rehab services. If they are receiving EPSDT PCS, like they have a prior authorization for that, they will be contacted by Conduit regarding long-term PCS. The support coordinator should inform the family to expect notification via phone or mail. And then if you'll ever want to call them directly, the LTPCS phone number is listed right there. And then we've got Louisiana Rehabilitation Services may provide assistance with services needed to pursue short or long-term employment goals, including higher education. And then if they have a statement of denial from OCDD, they may be eligible for Community Choices Waiver or the Adult Day Healthcare Waiver. And y'all can call OAS at that phone number to request to be placed on their registry. All right, so now we're going to move into section 3, components of support coordination. So your first step is going to be assessment and reassessment. Support coordination includes the following assistance: comprehensive assessment and periodic reassessment of individual needs to determine the need for any medical, educational, social, or other service. These assessment activities include taking a client history, identifying the beneficiary's needs and completing related documentation, and gathering information from other sources such as family members, medical providers, social workers, and educators to form a complete assessment of the beneficiary. After the initial assessment is completed, reassessments are done on a quarterly basis at a minimum and as needed when significant changes and circumstances occur. Okay, so at intake, y'all will contact the beneficiary or the legal guardian within 3 business days of the referral. At that time, a face-to-face in-home appointment should be set up within 10 calendar days to discuss what support coordination is and how it can benefit the individual. The individual should be asked about formal information documents they may have or can obtain prior to the CPOC assessment. So if they are receiving special education, we have to have their current IEP. And if they're receiving pediatric day healthcare or extended home health, we would need that current plan of care. So that's like one of the main things that holds up our initial CPOCs. So just make sure that at that first contact that you make with them, that you're having them obtain any of those records. The support coordination choice and release of information forms, so sometimes we call it a linkage form, or the support coordination freedom of choice. So that's what SRI sends to y'all to notify you that they've chosen you. So that form must be used to obtain all plans, evaluations, assessments, and documents that OCDD has developed or used in connection with its determination that the beneficiary is eligible for services through the Developmental Disability Services System, including the statement of approval. So y'all will send that linkage form to your LGE. They have a 5-workday turnaround to send you the SOA and then any documents that they use to make that determination. And then we've got a sample of the linkage form and Appendix K. The support coordinator will use the Medicaid eligibility verification system to determine if the beneficiary is eligible and remains eligible for Medicaid. And y'all will check for continued eligibility monthly. And if they ever become ineligible for Medicaid, they are no longer eligible for support coordination and closure procedures shall be followed. And we've got a whole transition closure section in the handbook. And then you can always let the family know if their Medicaid gets reinstated. They can call y'all directly if it occurs within 6 months. If it takes longer than 6 months, they would need to call SRI and we'll do a brand new linkage. So y'all would have to treat that as an initial client. But if y'all reopen it, you would keep those same CPOC service dates and you would just reopen them under the same case number. A face-to-face in-home visit must be conducted within 10 calendar days of the referral. Determine if the individual accepts support coordination and agrees with the contact requirements, including the required face-to-face meetings. The individual is often overwhelmed with everything they're being told in this first meeting. Do not expect them to remember everything, even if you're providing information in writing. Review this information as often as is necessary. All right, and then this is a list of some of the documents that y'all are going to go over with the family at that initial meeting. So we've got Appendix D, services available to children. Appendix E, the Medicaid services chart, and y'all should explain and review it with special emphasis on medical equipment and supplies, PCS, and home health. Appendix O is your rights and responsibilities that y'all are going to get signed. Appendix L is a blank CPOC, and I did have an SC tell me that I need to add the typical weekly schedule to that, so I will get that sent out to y'all again. So you should open up your, which I think I'll talk about signatures in a little bit, but at that initial meeting, everyone will sign the CPOC signature page, and then you'll complete the typical weekly schedule. You'll give them a copy of the appeal brochure, the complaint form, managed care complaints, voluntary opt-in to managed care for Chisholm class members, and then any of y'all's like agency policies that y'all are required to have, like your HIPAA and confidentiality, referral to EPSDT screening provider if that's requested, and then go over the availability of formal and non-formal services.
So, is this even working? I don't know.
When you're going over the Medicaid services chart, yes, we're saying emphasize DME, EPSDT, and the home health, but you've taken this child's medical and social history. So you should have an idea of what services you need to emphasize to them, and it should be tailored to that particular child. Yeah, go over everything, but you guys should know more than we do what this kid needs because you've done the intake work, right?
All right, so then assessment must begin within 7 calendar days of linkage, and that's the process of gathering and integrating formal and informal information relevant to the development of the person-centered CPOC. The formal information is going to include medical, psychological, social, and information from OCDD, and then informal information is anything gathered from discussions with the family and the beneficiary, and may also include talking to friends or extended family. The SC is to obtain all assessments and evaluations and documents that OCDD used to determine eligibility. And then if they're in special education, the current IEP, if they're receiving home health or pediatric day health care, those current plans of care, and then any other assessments by professionals that are required to obtain CPOC approval. The SC is to contact OCDD, schools, pupil appraisal, and healthcare professionals for necessary records, ask the individual about documents they may have or can obtain from their school, and follow up on requests for records. The SC is encouraged to collaborate with local educational agencies to enhance comprehensive coordination of Medicaid services across settings. The SC may need to assist the beneficiary with arranging professional evaluations and appointments, including well-child visits or EPSDT screening services, and follow-up on evaluations. The information provided as a result of these visits could prove critical in the assessment that will be used to develop the beneficiary's person-centered CPOC. So if they're not sure what services they could benefit from, refer them for a screening. SC, so y'all will develop and periodically revise a specific care plan that is based on the information collected through the assessment, that specifies the goals and actions to address medical, social, educational, and other services needed by the beneficiary, includes activities such as ensuring the active participation of the eligible individual and working with them and others to develop those goals, and identify a course of action to respond to the assessed needs of the eligible individual. The CPOC is your blueprint for assisting the individual and is developed through a person-centered planning process. It's led by the individual and designed to meet their needs. The CPOC must be completed in a face-to-face in-home meeting with the individual support team. The individual and the legal guardian must be present. So at minimum, it's made up of the individual, the legal guardian, and the support coordinator, and then any other people that they choose that know them best, such as family, friends, or other support systems or direct service providers. And all references to the individual include their representative or legal guardian. And then everyone present at your CPOC meeting must sign the CPOC participant's signature page in the planning participant's box. A competent major is someone that's 18 years of age or older and has not been legally declared incompetent. So in ELSIS, whenever they turn 18, y'all are going to mark them as a competent major, and it's going to unlock a question on if they're able to direct their own care or not. So if they are able to direct their own care, then you should talk directly to them and have them sign all documents. But they may choose to have an authorized representative by completing Appendix M, the authorized rep form. And then if they're unable to express their preferences due to a disability for which an accommodation cannot bridge the gap, the SC should document why they believe they're not able to direct their own care, and then you would have to have an authorized rep form on file or a supported decision-making agreement. And y'all can refer to the handbook for more information. The CPOC is based on the identified needs and the unique personal outcomes envisioned, defined, and prioritized by the individual. It must include agreed upon strategies to achieve or maintain the personal outcomes using appropriate natural community supports, non-formal and formal paid services. It must include timelines in which the personal outcomes can be met or at least reviewed, and the support coordinator is responsible for providing complete and clear information to assure the individual can make informed choices regarding the supports and services they receive and from whom. So again, y'all should use the Medicaid services chart to discuss all available Medicaid services.
Also, we saw this a lot in the cases this year that Health Standards surveyed. Disability Rights gets to a copy of all those cases, and they go through them with a fine-tooth comb. There were cases where ASD was a diagnosis and ABA was not discussed or documented as discussed. Make sure if they have an autism diagnosis that you are documenting that you're asking if they want ABA and then following that all up, because that was something we got popped and hit with a lot this past year.
All right, and don't wait for an individual to request a service. If you see a need for a service, offer it to the individual and document their response. So was it requested, declined, or on hold? If the individual may need additional services, but it's not clear, suggest appropriate evaluations to determine whether there is a need. One of the primary responsibilities of the support coordinator is to follow through with requests for services.
And guys, when we get your quarterly report at the 5th of every month, and I see back from the SC from Kim that says poor SC follow-up. Guys, that's not acceptable. Y'all have to follow up on all the services until they receive them.
And y'all may be doing the work and you're just not documenting it.
Correct. Document.
Do something, make a service log for it. You call a provider, make a service log.
Not documented. It did not happen.
All right, so the CPOC is going to be completed electronically in ELSIS. The SC should review a blank copy of the CPOC before conducting each meeting. The CPOC is designed to briefly summarize important information so it can be reviewed and considered in evaluating the need for proposed services and supports. Information relevant and applicable to justifying services requested by the individual must be provided. Information critical to the individual's health and safety should be documented in the CPOC, and the CPOC should always emphasize the individual's personal outcomes, and the goal is to provide supports and services in a person-focused, cost-effective, and accountable manner. So we've got 6 sections of the CPOC that we're going to go over. The initial portion is pretty self-explanatory. Y'all will include current contact information, mailing and physical address, good contact numbers, double check the Social Security and Medicaid ID, their ICD-10 diagnosis. Whenever you list a legal guardian, make sure that you're putting the relationship of that person in the box beside their name. And then if they're a competent major, y'all are gonna document if they can direct their own care. So this is what the demographics section looks like. I don't think I have any notes for that. All right, and then section 2 is going to be the medical, social, family history. You will interview those who know the beneficiary best, provide information about the past and current situations in the beneficiary's life and about their family. Information included is relevant to the beneficiary's life today and provides a means of sharing social or family history. So make sure that y'all are updating that and kind of deleting information that's not applicable anymore if we don't need like a whole history of their school. We just need to include, like, there's not a ton of room in the CPOC.
Yeah, it clears up space.
It's supposed to be brief. And then I also have a lot of plans that come through with inconsistencies because y'all are leaving information in there from like 3 years before.
Supervisors are supposed to be reviewing the CPOC prior to it gets sent to Kim. Supervisors, y'all need to look for current information.
So it just makes it, and then also like, if y'all are talking about PCS, only talk about it in one section. Like we don't, then if something changes, you have to go find every section that you talked about PCS in. And so if we just have it in the medical diagnosis section, then you only have to update it there and the service need. So sometimes like SCs will copy information into multiple sections, and then I have to send it back because it's inconsistent because they didn't find all the different places where he talks about that one service need. And then if any information is ever unknown, just document that it's unknown, and then I know that at least it was addressed with the family. If there's only sketchy information available, remember that they're eligible for screenings to determine their needs. It's the support coordinator's responsibility to help them access those screening services. And in addition, it's important to remember that psychological and behavioral services are available and should be offered. So always document the offer of services and the response received. All right, the past section, anything significant with their prenatal health or birth, the nature and cause of disability if it's known, the age that they received their diagnosis and who made that diagnosis. And again, if any of this is unknown, just document that it's unknown. Any early intervention services that they received, like early steps, any placement history outside of their current placement. So it could be different family members that they lived with, foster care, extended hospitalizations, any past medical history, surgeries, or hospitalizations. So anything relevant to their care today that occurred, over a year ago, you could put it in the past section. And then the events that led to the request for services at this time. And if there are no services to coordinate, again, that's fine. They can still receive support coordination. But just make sure that y'all are documenting that the family is aware that support coordination is optional and that declining it will not affect their eligibility to receive Medicaid services or their placement on the registry. EPSDT support coordination is optional. All right, in the present section, you're gonna list the names and ages of all household members, briefly discuss their family situation and social support network. So we're just trying to identify who their natural supports are. Make sure that you address both parents if they don't live in the home. If they have any legal guardianship documentation on file, document that you have that. Any relevant social, environmental, or health factors that impact the beneficiary. Do they have access to the community or transportation? What is the source of their household income? Any desires and requests, any education needs. And again, like all these bullet points are just trying to identify service needs. So if they don't have access to transportation, did we offer the Medicaid transportation services? Could they be referred to the Flexible Family Fund? Do they need help accessing any community support? Education needs? Do they need a special ed evaluation? Do they need help enrolling in school? If they're homeschooled, is it registered with the Department of Education? All right, then your medical diagnoses section is going to be a brief narrative description of the person's health history, their current medical condition, and medical needs should be included. So list all their diagnoses and what current formal information document you have on file to support their qualifying diagnosis. If any diagnosis is parent states and y'all do not have documentation to back that up, either document what y'all are doing to try to get that documentation, or did we offer to have them evaluated so that they can have that formal diagnosis on file. List all their medical specialists, so their name, the specialty of that doctor, how often they see them, and then the last visit or upcoming visit. And then what I'm really looking for here is if they're overdue for any visit, that we offered scheduling and transportation assistance. And then also we focus on dental care, that's current, or if they don't have a dentist, did we refer them for that? Their primary care provider, they should be getting the recommended well-child visits. Any behavioral health care that they receive, we want that documented, so that I just kind of have an example. And it helps me if y'all kind of like push the enter button and start a new line for each doctor. It's just easier for me to see which ones they're overdue for. And then list all medications and what they're prescribed for. And then we're going to address any vision, hearing, communication, mobility, toileting needs, or dietary needs. Do they need assistance with their activities of daily living? And if so, with PCS offered? And if it's requested or received, what ADLs will their worker assist them with? What therapies do they receive at school, and were community therapies offered? What assistive devices or DMEs do they have or need? And then any special procedures or medical equipment like G-tube, trach catheters, how often? And then if they do have any of those, did we offer skilled nursing or extended home health? And then you've got your psychiatric behavioral section, which is going to be a narrative description of the person's psychiatric status, diagnoses, and significant behavioral concerns. So address behaviors both at home and at school. Describe the behavior, so what exactly does it look like, and how often does it occur, and try not to use words like frequently or rarely. Try to give me a more detailed example of what their behavior looks like currently. And then any significant behavioral incidents, and try to document the month or the year when that occurred. And then if they do have behaviors, are there any known triggers? And if they do have a behavior, what is the family or the school doing when that behavior occurs? How is it being managed? And then what behavior services were offered and which ones are received or requested? And then if the beneficiary has an autism or a related diagnosis, or has even been labeled, even informally, as having autism or a related diagnosis, please make sure you are either connecting the class member with ABA, referring for testing to assess the need, or documenting that the family declined these services. And if declined, please revisit ABA with the family at least annually. And as you know, autism services can be most effective when delivered as early as possible in a child's life. Services usually should begin at ages 2 to 6, and the needed early connection is sorted if SCs fail to identify ABA as a possible therapy and arrange it unless declined. All right, and then we've got an evaluation documentation section in the plan of care for y'all to list the dates of formal information documents that you have on file. At least one current formal information document is required to receive approval on a CPOC, and current means that it was less than a year old at the time of your meeting. All right, and we already talked about that stuff. Okay, and then you have to have a current SOA on file from OCBD, or you must have redetermination as a service need if it's already expired. So sometimes we'll get initial clients that have not completed their redetermination. So you would just list the dates of the expired one in the SOA box, and then you would add redetermination as a service need. And then if the SOA is going to expire that CPOC year, you would also add redetermination as a service need. And then it's helpful if you go ahead and document the date that the SOA expires in the service need like description box. And y'all had a question?
I don't know if this is a dumb question, but I've been getting some SOAs without like an expiration date. So what do
I had that the other day. Okay, yeah, so
Expiration date.
some of the LGEs will not put an expiration date on the statement of approval. So it's going to be on the letterhead from your LGE. It's going to tell you when they were added to the registry, when like you'll use the SOA date at the top. But if it does not have an expiration date, then you would mark it as permanent. So it may not specifically say that it's permanent, but if it doesn't list the expiration date, it's permanent. And then if you look at the very bottom of that evaluation documentation section, you've got SOA, and then right below that, you would put the expiration date if there is one, and if there's not, you would check the permanent box. And then we also have an other box at the very bottom. So if it's something that's not listed there that you have on file, you would list the date, and then below that describe what document that is. But we've got psychologicals, special ed evals, the current IEP, home health plan of care, and then we've got a box for Form 90 or medical record, pediatric day health care. So for kids that are not in special ed, are not receiving PDHC or extended home health, you could have any of those documents on file, and that would work as your current formal document. And then we do not have to have a Form 90 on file, but that would count as your current formal document. All right, then we've got the service needs section. Y'all are going to do a service strategy and description, identify how the need was determined, if it's requested, and if not, why not. The primary goal, who's going to provide the support, and then if it requires PA tracking, y'all are either going to check the requires PA tracking box, or you're going to select the reason why it's not being tracked, and the amount of service approved. Identify, yeah.
So if they have a current psychosocial evaluation, or what was the other one?
So we've got psychological, psychiatric.
Psychiatric evaluation, and sometimes the special ed eval I see could serve as the CDE for ABA. So if they have those evaluations already, there's an ASD diagnosis and they're recommending ABA, they don't need to go get a new evaluation for ABA. The only time they might need to go get a new one is if it's really old. So say the kid had one at 3 and they're 12, and now they want ABA, you might need to go get a new one. Are y'all seeing any of that doubled up?
I mean, I definitely get copies of them that have, like, you'll go to the bottom of the evaluation and it'll specify that we recommend ABA and it'll give the family resources
So if you
for how to get.
have that already, please do not send these families to go chase down getting a CDE. It takes up that time, and it's gonna delay them getting ABA, and it's taking up time that somebody else who doesn't have one already needs. That make sense?
So if y'all have a family that's getting a psychiatric eval, make sure that y'all are requesting a copy of that from the family or the provider so that you know what's recommended in there. Okay, so in the service needs section, y'all are going to list everything that they're currently receiving, and everything that's requested. So both Medicaid and non-Medicaid, clearly identifying each service and the amounts approved. So each service need needs to be listed separately. So if they're requesting or receiving speech therapy at school and in the community, those are two separate service needs. Make sure to select the appropriate service from the service strategy pick list. And the description box is there to clarify the service need, but please do not put provider names. Do not put words like requested. That's going to change over time. So like for PCS, it should just, you would select PCS from the drop-down box, and then you would just type in PCS in the description box because that one's obvious what's requested. But it just makes the tracking a lot easier. If you need to change the provider, all you have to do is bring forward a change in service tracking log. Y'all do not have to enter an interim CPOC and resolve PCS1 and add PCS2. You would just open a change in service tracking log and start the process over. So everything listed in bold is a particular service strategy pick list option, and then it kind of goes into detail about what services may be included under that particular pick list. So for medical equipment and supplies, that would include one-time durable medical equipment like wheelchairs, and then also your ongoing DMEs like formula, trach supplies, or G-tube supplies. Specialized behavioral health could encompass psychiatrists, behavior meds, counseling, behavioral health rehab, et cetera. School, you just need to include things that are on the IEP, like therapy, assistive technology, social worker, or nursing. Transition, y'all will add that if they're going to be 20 and a half years old. Redetermination if their SOA expires. Anything that they're requesting through OCDD, like flexible family fund, their CSOC services, any needed evaluations, if they're requesting an EPSDT screening exam. And then for physicians and professionals, it's just the ones that they need a referral to or are overdue for a visit with. If y'all want to list every doctor as a service need, you can, and then you could update your visits like in your quarterly, but you don't have to list every single physician as a need. Then you're going to identify how the need was determined, and then if a service is not being requested now, so if you uncheck that requested box, it's going to unlock the if not, why not box, and you're going to have three options. So carried over resolved is if it's no longer an identified need, so we don't need to talk about it at every quarterly meeting moving forward. So if it was something that they wanted that they no longer want, you would uncheck, like enter an interim CPOC, uncheck requested, and then mark it as carried over resolved. The next time that I approve the CPOC, it will fall off, and then y'all won't have to go over it at your quarterlies. The other one is going to be family does not want. If we know it's a service that's been identified, but the individual declines the service, and then y'all will use other explain next page if the need for the service has been identified, but it's placed on hold. And then you're always going to explain why you marked it as either of those in the additional information box. And then you'll select the primary goal, and then the check boxes are going to be used to indicate if the service is currently received, and that's another one that is kind of a common CPOC correction. It's like the medical diagnoses section says that a service is received, and then I get down to the service needs section and it's marked as not received, then that's an inconsistency that I'll send it back for. And then check the appropriate box of who will be providing or funding the service. So your options are Medicaid, school, community, family, and you would use family if it's being provided by private insurance or if the family's paying for it out of pocket. And then the last one is OCDD. And then requires PA tracked by SC must be checked for all requested Medicaid services that require a PA unless both a valid reason for not documenting it is selected and how the SC will ensure the service is received is documented in the additional information section. Indicate the amount approved, and then assure and document at the time of the CPOC meeting that the individual understands that services and goals may be added whenever a request is made if they choose not to access a service when the need is first identified. So y'all can enter as many interim CPOCs as y'all need. If you make a monthly contact or the family calls you at any time to add a service need, you would just pull forward another interim. All right, and then our valid reasons for not doing PA tracking. So the first one is going to be if a PA is not needed to receive that Medicaid service. So we talked about some of the MCOs do not require a PA for diapers or therapy if it's under a certain limit. So it's still being funded by Medicaid, it's still being requested or received, so it's going to remain a service need, but you would just not check requires PA tracked by SC, and then you would select reason 1, PA not needed. If the PA is issued monthly, you would enter that monthly PA into a tracking log as documentation that it's issued monthly, and then you would untrack it and use PA issued monthly as your valid reason. If it's a medical supply that the extended home health nurse is ordering and tracking, then we do not have to do tracking on top of that. And that would be included in the home health plan of care. If the beneficiary is placed on a wait list, and I want to say I have more information on this a little bit later, so you would complete the wait list placement steps as identified in the handbook. So you would have a PA tracking log, you would send your referral to the provider, you would confirm the wait list placement, you would notify the PAL. Once all that's done, and the family wants to remain on the wait list for that particular provider, then we can untrack it. And then you would just restart PA tracking when their name comes up on the wait list. And then like we talked about earlier, y'all need to follow up with any provider that they're on a wait list for every month. And then that way we know when their name comes up.
I'll go down a wait list for 2 to 3 months, should I continue with the APA providers?
It depends on what the family wants to do. Like if they have a particular provider in mind that's close to them that they want to wait for, then.
But document that you offered to look for other APA providers, and they'll say, no, I want to be on the wait list for this provider. You're covered.
All right, and then if they are receiving the service without a PA, this only applies to OT, PT, and ST. Those providers have, I think, up to a year to submit for their PA. So we do have a few providers that wait. So y'all can refer to Appendix BB4 for more of an explanation on that, but that does not happen that often. And then if they're in CSOC and it's a CSOC service, y'all would use reason 6 to document why we're not doing PA tracking for that. And again, I go into much more detail about that in the handbook. So this is what the service needs look like. All right, and then Section 4 is your additional information and CPOC participants. The beneficiary and the legal guardian must be present for the CPOC meeting. The signature page is going to be a paper form. It cannot be done electronically. So all planning participants, which is anyone present at your meeting, and again, that has to include the beneficiary and the legal guardian, must sign the printed ELSIS CPOC signature page. So that's going to be in that planning participants box at the top. And then below that, the beneficiary or the legal guardian will sign off on their line. the SC will sign off, and then make sure that the SC supervisor is signing off on the very bottom of that CPOC signature page before y'all submit it to me.
And SC supervisors, make sure there's a tab that says see service tickets. You have to review the service tickets to see that everything that was documented by your SC has been incorporated in that plan of care. As a supervisor, you're supposed to review that information. So do not submit that CPOC to Kim without reviewing the service tickets.
Okay, so this slide is about the paper copy of the signature page, and then this one is about what y'all put into ELSIS. So that should directly match your signature page. So the planning participants that signed on the paper copy should be listed in ELSIS under the CPOC participants. The signature date of the participant guardian's signature on the CPOC signature page paper form will be entered into ELSIS, and then y'all will sign off on it to submit it to the supervisor, and then the supervisor will sign off on it to submit it to me. And then also on section 4, next to the planning participants, there's going to be an additional information box, and that's where y'all can include information regarding service needs and support. You can list the names of all service providers, so any that have been chosen, and any additional strategy information. So if there are any barriers, what we're doing to address that. And then if we use that waitlist placement reason for not PA tracking, you have to document that you offer alternative providers and document the family's response, that you confirmed the waitlist placement with the provider, that we notified the PAL, and then how you're going to ensure that they move up the wait list, and y'all will follow up at least monthly. And then if family is ever checked instead of Medicaid for a service that's typically covered by Medicaid, explain why. So is it private insurance? Is the family paying for it out of pocket? And then if any need is marked as carried over resolved, family does not want or on hold, explain why. And then y'all are always going to document the explanation and review of the Medicaid services chart, services available to Medicaid eligible children, and that y'all provided information on EPSDT screening services. And then you'll identify how often the goals will be reviewed, and the minimum is quarterly. So that's what section 4 looks like. And then section 5 is where the SC supervisor is going to approve the CPOC. So again, when you're submitting the plan of care, the SC supervisor is agreeing that they reviewed the formal information documents listed under evaluation documentation. They reviewed the prior CPOC, all service logs and quarterly reviews, looking for identified needs and the status of requested services. The entire CPOC must be reviewed to ensure that all identified needs are addressed, all required information is included, information is edited and updated, and no discrepancies exist. So whenever y'all are ready to submit the plan to me, you'll check the submit for review by LDH box. And then, like Tracy said, there is a see service tickets button, and that's gonna pull up like a new tab in your browser, and you'll be able to review all the service needs from that CPOC year. So again, sometimes a plan looks great, and then I go to the service logs and I see that recently they requested a service that is not addressed in that new plan of care. All right, so I will review the CPOC to assure that all components of the plan have been identified. If any discrepancies exist, I'll list them in the approval denial notes box and return the CPOC for resubmittal. And always review that approval denial note box, not just on denied CPOCs, but sometimes I'll approve the CPOC and still have a note for y'all there. An approvable initial CPOC must be completed and sent to SRI within 35 calendar days of linkage. If the approvable CPOC is submitted timely, the PA will begin on the CPOC participant signature date. If the CPOC is late, the PA will begin on the approvable CPOC submit date. And then annuals, the meeting can be held no more than 90 calendar days prior to expiration. and the approvable annual must be submitted within 35 days of CPOC expiration. So for initials, you can refer to the aging report, and then for annuals, you can refer to the CPOC update report, and it's going to give you that first CPOC meeting date and then the due date of the approvable CPOC. And then Appendix Z1 is going to be for all initial CPOCs and anyone labeled special needs and ELSIS. And then Appendix Z2 is going to be on the 10% of CPOCs that are randomly selected for monitoring. So whenever the SC supervisor clicks the submit button, you'll be notified if it was one of y'all that got selected for monitoring, and then you would need to send me Appendix Z2 and the documents listed. But if it's a regular annual that's not special needs, not selected for monitoring, y'all will just file the records. The SC is responsible for requesting and coordinating all services identified in the CPOC immediately upon completion of the CPOC and prior to approval from SRI. Since approval of Medicaid state plan services is through the prior authorization unit, there is no reason for the SC to wait for SRI approval before making referrals for necessary services. Again, the CPOC does not control the services. The CPOC approval process only controls payment to support coordination agencies. So as soon as y'all hold your initial meeting, if they're requesting a service, add it as a service need, open up your PA tracking log and start following those prompts. And that's what the CPOC approval section looks like. And that little button on the right is that See Service Tickets button. So when the SC supervisor submits the annual, so they check that like submit for review by LDH box, and you click it, a little pop-up window is going to come up and tell you if it's selected for monitoring. And then there's also, I think it might be the CPOC update report, that'll tell you, there's like a column there that'll tell the SC if it was selected for monitoring. All right, the typical weekly schedule is going to be a paper form, and that's just a tool that y'all use to assure services are delivered at appropriate days and times and do not overlap unless it's medically necessary. Make sure that you include all services that they're currently receiving or that are requested, showing the beneficiary is in school, at home, or participating in other activities. The schedule can be forwarded to in-home providers and prospective providers to support and clarify prior authorization requests. If prior authorization is denied and not appealed, or if you ever need to update the schedule for any other reason, you would update it on the paper form and then send it to any providers that it would affect. All right. Try to see how much I can get done in 30 minutes.
As soon as we can. We got the room all day, all day.
All right, so now we're on part 4, coordination of services, referral and related activities. Support coordination includes referral and related activities such as scheduling appointments for the individual to help them obtain any needed services, including activities that help link the individual with medical, social, educational providers, or other programs and services that are capable of providing needed services to address identified needs and achieve goals specified in the care plan. So once the needed Medicaid services have been identified in the CPOC, it is the support coordinator's responsibility to coordinate the service. Again, do not wait for SRI to approve the CPOC. The SC should provide as much assistance as possible to the family to identify and obtain other non-Medicaid services that are identified in the plan. The CPOC is considered holistic, therefore the SC is responsible for coordinating all identified service needs, including paid and unpaid support, as well as non-Medicaid services. The SC must be knowledgeable of potential community resources, including formal resources such as SNAP, SSI, and housing. Some Medicaid services such as PCS, home health, and durable medical equipment require PA. So typically the provider of the service will develop and submit an application to the prior authorization unit. Requests may be denied if the item or service requested is not medically necessary or if it's outside of the scope of services covered by Medicaid. A notice of denial will be sent to the beneficiary, the provider, and to the support coordinator, and then the beneficiary will have the right to appeal, and y'all will help with that. All right, so we're gonna talk about the prior authorization liaison, or the PAL. The PAL unit was established to facilitate the PA approval process for Medicaid beneficiaries under age 21 who are on the registry. So again, that's our Chisholm class members. The Chisholm versus LDH lawsuit settlement stipulates that the SC is notified of request, status, and any delays to the PA approval process. The PAL will maintain a tracking system to ensure SCs remain aware of the status of PA requests, submission, decision dates, and reconsiderations. The PAL will assist with problems on each PA request so that a decision is rendered as to medical necessity. PA requests are given to the PAL when the request cannot be approved due to lack of documentation or technical errors. The PAL will attempt to resolve the problem, so within 24 hours, the PAL will make the initial contact by phone or fax with the provider, the beneficiary, and the SC. If the issue is not resolved after 10 days, a notice of insufficient documentation is sent to the provider, the beneficiary, and the SC, advising them of the specific documentation needed. And then the beneficiary has 30 calendar days to either supply the needed documentation or notify the PAL with the appointment date that has been made with the health professional to obtain it. So y'all's role is to communicate promptly with the PAL to facilitate requests for information, communicate with the individual and provider, and provide assistance in getting the documentation needed to support the request, follow up so that a PA decision is received instead of having the service denied due to a lack of information, and then track the status of requests. So advise the PAL of providers not actively developing requests, inform the beneficiary of their right to choose another provider, and assist them in locating another provider. If a notice of insufficient documentation is received, assist the beneficiary in getting the documentation. And if you're not sure that you'll have enough, help them schedule an appointment to get the documentation, and then make sure that you inform the PAL that that appointment has been scheduled. When SC closes a PA tracking log that had a PAL referral sent to LDH, the SC should notify LDH of the closure date and reason. This allows LDH staff to focus on active PAL referrals. So you all would send the referral to PAL and check box 8, and then explain why that was closed and attach your documentation. So the LDH PAL is Danielle Boykin, and then Gainwell Technologies PAL is Monica Anderson. And then for a list of the MCO PALs, you will refer to Appendix X2 MCO contacts for SCAs. And we do have one fax number and one group email address for each MCO PAL. And then below that, we've got your single point of contact for the PAL at each MCO. And then, like all of Appendix BB goes over Medicaid prior authorizations. So we've got those PA forms that the providers use, some of the prescriptions, sample PAL notices, sample PA notices. So to summarize, if additional information is needed, the PAL will contact the provider, the beneficiary, and the SC within 24 hours. Y'all will help to get the additional information, and y'all will receive a copy of all notices, so approvals, denials, reduction in services, and requests for additional information regarding the requested service. Okay, so y'all play a role in the PA process by assisting beneficiaries in identifying services that they will request, providing the specific medical forms that the physician must complete. So like if they're requesting PCS, we would give them a copy of the Form 90, and assisting with scheduling of physician appointments, transportation, et cetera, to have the forms required for a PA request completed. Locate providers willing to submit the request, assisting if necessary in getting documentation needed to support the request, making sure providers submit requests timely, and tracking the status of the request, communicating with the PAL, notifying them of any upcoming doctor's appointments, and helping to supply any missing documentation to support the medical necessity. Following through with requests for services until the PA is either approved or denied based on medical necessity, and assisting the beneficiaries making the decision about whether to appeal any denial of service, and assisting with the appeal if they decide to appeal and want your assistance. Even if a prior authorization is not required for the Medicaid service, or there is a valid reason why you're not tracking it, the SC is still responsible for coordinating the service. So you'll play a role in the process. You're still going to identify the service. You're going to help them locate a provider. They may still need documentation to support the request to receive it. And y'all are still going to follow through with the request to ensure that service is received. All right, so the first step we're going to talk about is locating providers. So at the beginning of every month, y'all are going to verify Medicaid eligibility and establish their enrollment type. So once we know who covers their physical health, behavioral health, and transportation, then we'll know how to locate a particular provider for that service. So for fee-for-service, PA requests are acted on by the prior authorization unit of Gainwell Technologies. And for managed care services, PA requests are handled by the individual MCO. So I know we talked about this in the very beginning, but again, a B linkage is enrollment in managed care for specialized behavioral health and transportation. So that means that they would be getting their physical health through fee-for-service. And then a P linkage is enrollment in an MCO for all of their services. So for physical health, it's either going to be Gainwell or the MCO. So if you need a fee-for-service provider for physical health services, you can always call the specialty care resource line to find medical providers of various types and specialties for your beneficiaries. It's an automated resource directory of all Medicaid enrolled providers of medical services, mental health clinics, and many other healthcare professionals, and the database is updated regularly. You can also go to the Medicaid website. If you do go to lch.la.gov, you will need to click on locate a provider, or you can just go to that direct website. And then to search for PCS providers, that's going to be a specific provider specialty under personal care services provider group. And then you can generate your list to either look at your whole region or a specific parish. To locate an MCO provider for physical health, you can either go to myplan.healthy.la.gov. You would then need to click, there's like a choose tab, and you would say find a medical or dental provider. And then since this is for physical health, we would click on the medical provider tab, and then you can search by zip code, city, or parish. And then you can search for specific. So the myplan.healthy.la.gov has all 6 MCOs there. So if you have a particular provider in mind that you want to see which MCO they request, you can use that one. And then for them, PCS is going to be accessed by selecting personal care attendant from the provider specialty field. Your other option is to call the member services line at your beneficiary's MCO. And then the third one is going to be to access the MCO's website to identify their contracted providers. And then I've got, I think it's BB7 is going to have screenshots of all of the different managed care organization provider locator tools and how to look for PCS providers for each MCO. So if y'all are ever having trouble with those tools, just let me know and I may be able to walk you through how to find a provider. All right, and then behavioral health is either going to be through the MCO or through Magellan if they're enrolled in CSOC. So same way that we look for physical health providers, y'all can look for behavioral health MCO providers. Instead of medical, we're going to select the search by behavioral health provider tab. And then if you need to search for a behavioral health therapist, you can select the outpatient therapy from the provider specialty. You can also call the member services line at each MCO or access the MCO's website to identify their contracted providers. And then to locate evidence-based programs, again, you can go to the LA Evidence to Practice website, and they have an interactive map, which may help y'all find those particular providers. And you can also contact their MCO and ask for help from a behavioral health care manager, or contact Magellan for youth enrolled in CSOC to find an in-network evidence-based program provider. And then for our CSOC children, you can contact Magellan directly at that phone number, and then y'all should also know who their wraparound agency and wraparound facilitator is, so let them know if there are any additional behavioral health services that you want to add to their plan of care. And then again, that therapeutic group home, psychiatric residential treatment, and residential substance use are still going to be authorized by the MCO. Transportation services, the MCO is going to cover NEMT and NEAT, and the transportation phone numbers are found on Appendix C. And if they do need the non-emergency ambulance transportation, there is a particular phone number for them to call, which is going to be on Table 4 on page 21 of the handbook. Dental services are either going to be with DentaQuest or MCNA Dental. And when y'all run their Medicaid eligibility verification at the beginning of every month, it will identify which plan they have. All right, so PA tracking begins with the request for the service, not when the choice of provider or prescription is received, and not when the CPOC is approved. When the beneficiary requests a Medicaid service that requires a PA, add the service need to the CPOC, select the appropriate service strategy, and enter a description. Then you're going to check that it's requested by the family. You're going to check the Medicaid box, and then you're going to check requires PA tracked by SC, or you're going to select a valid reason why you're not doing the tracking. If Medicaid and PA tracking are checked, then you can run your tracking required action report analysis, and it's going to start prompting you what to do. So the first step is going to be to open up a PA tracking log, which will be done by going to the beneficiary's tracking history and clicking the Add New Tracking Log button. So as long as you have Medicaid and PA tracking checked, you'll be able to select that service need in your tracking log. Determining if a service need requires a PA for fee-for-service, you can refer to the Medicaid services chart. And then one resource we have for the MCOs is they all have a PA lookup tool that can be used to determine if a service requires a PA or not. And I have links to all of those, and then this is also included in one of the appendices. For ABA, when the beneficiary has Medicaid as their secondary insurance, there is a website for ABA secondary PA requirements. So sometimes if primary insurance has already issued a PA, then the MCO will kind of honor that and not make them get an additional PA.
Right, so they just need to submit the approval from the primary insurance. Yeah.
Which most of the ABA providers know how to do that.
Yeah.
For Medicaid services that do not require a PA, you would check requested because they still want the service, Medicaid because Medicaid's still going to pay for it, and then you would select the reason 01 PA not required. So the electronic PA tracking log is an important tool for several reasons. It's going to help you assure that they're receiving the services that they requested. It's going to remind you to contact the provider. It's going to remind you if we don't have a copy of the PA form, it will remind you to do required PAL referrals, allow you to know at a glance when and if services were or were not approved, serve as a reminder of when the notice should be sent to the provider to renew the service, allow you to document information about the PA decision notice, and allow you to document that you offered or provided appeal assistance to the beneficiary and provided the appeal brochure. So it's going to be used to document the nature and specific amount of each service being sought, provider and PAL referrals, provider contacts, and information about approval, denial, and appeals. A separate PA tracking log is completed for each service that requires a PA and for each PA cycle. So once a PA expires, it'll prompt you to start a renewal tracking log. So that we'll send a reminder to the provider to notify them when their PA expires. Make sure that you always enter a new choice of provider date, because that's going to determine when you need to send your referral and do your 15-day and 35-day contacts. So date of service request always remains the same, because it's not like they quit requesting PCS. It's been requested that whole PA cycle. But always enter a new choice of provider date for your renewals. And then a new change in service tracking log is used for changes in existing services. So if they need to request additional hours or they need to change providers, again, keep the date of service request the same as the previous tracking log. Okay, and we are making some significant changes to the PA tracking process to make the managed care PA tracking more in line with fee-for-service. This is not going to go live until January 1st, so that like y'all's quarterly report and the tracking required action report, we can kind of have a more smooth transition of the change in referrals and timelines. So this is what it's going to look like for legacy Medicaid. And then this is what it's going to look like for MCOs. We're not going to have to do any of the first referral and second referral. That's going to go away, and it's going to be more in line with fee-for-service. And then instead of having like 6 referral forms, we only have 2. So I'm going to go over that. Okay, so when someone requests a Medicaid service, the first step is to obtain required documentation to support the medical necessity. So when they request a service, we provide the medical forms, assist with scheduling doctor's appointments, transportation, et cetera, and assist the beneficiary and provider in gathering the appropriate documentation needed to support the request. Also, upon request, we're going to offer a freedom of choice. So give the individual a choice of providers unless they're already satisfied with their provider, and assist them in contacting prospective providers and finding out if they're willing to submit a PA request. So if the family needs help finding a provider that's accepting new beneficiaries, y'all can do that. And then once they make the choice of provider, we're going to enter the date the beneficiary chose the provider and the provider's name on the EPSDT PA tracking log. You're going to have the beneficiary list their choice of provider on the choice of provider form. And then within 3 calendar days of the date of choice of provider, you're going to send Appendix V1 referral to provider. And again, this is going to be one form for everybody, regardless of if they're in fee-for-service or managed care. And then if it's an initial CPOC, you would want to do that referral within 3 days of that initial CPOC. And if it's a client that's already been approved, it would be within 3 days of the choice of provider. All right, and then within 15 calendar days of the referral to provider, you're going to contact the provider to confirm that they're working on the request and see if they need any assistance gathering information. And then within 35 days, you're going to contact the provider and ask if the PA request has been submitted to the fiscal intermediary or for fee-for-service or the beneficiary's MCO for managed care. So there's going to be a date packet submitted to FI/MCO. So if it's fee-for-service, the fiscal intermediary, that means that the provider submits it to Gainwell. If it's a managed care service, then they're going to submit it directly to the MCO. But it's going to be one box on there that'll cover everybody. Once the provider submits the PA packet to Gainwell or the MCO, you're going to enter the date the packet was submitted. If the SC receives a copy of the PA packet, you're going to document the date that you got it. If you don't receive it from the provider, there's going to be a not received box for y'all to check. And then if a notice of decision or a PAL notice is not received within 10 calendar days of the date the PA packet was submitted, you'll contact the provider and continue to follow up until the PA packet is approved or denied based on medical necessity. And then for any durable medical equipment requests, you'll give them 25 calendar days for them to respond to those. If a PA packet is not submitted within 35 calendar days of referral to provider, you're going to send Appendix B2, referral to PAL, you're going to check box 1. You should offer alternative providers, so if the family wants to choose a different provider, they always have that option, and then continue to follow up with the provider until the PA packet is submitted, and remind the beneficiary that they can change providers. So the referral to PAL has a list of all the different PAL contacts. So there's going to be 6 for the MCOs, and then if they're in fee-for-service, that's going to go to Danielle, and her contact information is listed. And then on the referral to provider form, y'all are also going to clearly indicate who the provider would need to submit the request to. So which MCO do they have, or are they in fee-for-service? And that should hopefully clear up some of the problems of providers accepting beneficiaries with like MCOs that they're not contracted with. All right, when you receive the notice of decision, you're going to enter the date of decision, the date you received the notice, the amount approved, the PA begin and end date, and then if the PA was not issued within 60 days, there's a box for y'all to enter why, and then the approval denial status. If a PA decision has not been received within 60 calendar days of the choice of provider, y'all are going to send a referral to the PAL, and you're going to check box 2, and again, inform the beneficiary about their right to change providers. If the beneficiary service is denied or partially denied, you're going to inform them of their appeal rights, go over the appeal brochure, offer to assist, document if you gave assistance or if they declined it and wanted to do the appeal on their own, the coordination of documents, the submission of documents to the appeals office, or if no documentation was available, the date the appeal was filed, and then if the SC did not assist with the appeal, the reason assistance was not provided, and if an appeal was filed, the response to the appeal and the final decision. If a service is denied or partially denied, explain that the beneficiary can receive the services or items that have been approved and appeal for whatever was denied. They do not need to choose between filing an appeal and receiving the approved services. Explain that services will be continued pending appeal if the appeal is filed within the 30-day appeal period. The SC must ask the individual if they need or want assistance with filing the appeal, and the SC must assist with an appeal if the beneficiary wants them to. All right, so the denial is going to be the only part where it's a little bit different. So for fee-for-service, if a service is denied within 4 calendar days, you're going to explain appeal rights, explain the provider can request a reconsideration, and explain services can be continued pending appeal if it's filed within 30 days of the notice of denial. Within 20 days from the date the appeal is filed, you check on the appeal status, and then within 90 days, we should have the final outcome of the appeal. And then you're going to fill out all of that information on your PA tracking log. Okay, and then for managed care, for services authorized by the MCO that are denied or partially denied, the beneficiary, the provider, and the SC will receive a notice of denial. The beneficiary may appeal the decision by following the appeals procedures sent to them, the provider, and to you by the MCO. If you do not have a copy of it when you're talking to the family, you can refer to the MCO's member handbook to review their internal appeals procedure, and then there's a link to all of the member handbooks on LDH's website. So again, you'll inform the beneficiary of his appeal rights, you'll go over the appeals brochure from the MCO, and you'll offer assistance with the appeal process, fair hearing if they want to request an appeal. If the internal MCO appeal decision is upheld, then the beneficiary has the right to appeal to the Department of Administrative Law. So for managed care services that are denied within 4 calendar days, you'll explain appeal rights, explain the provider can request a peer review, and then go over the continued benefits information. They are entitled to a continuation of benefits pending resolution of an appeal or state fair hearing when a previously authorized benefit is terminated, suspended, or reduced prior to the expiration of the current service authorization. Then within 20 days of that appeal, you'll check on the appeal outcome and then enter all of the information into your tracking log. So after the internal MCO appeal is exhausted, then you'll move on to the Department of Administrative Law state fair hearing. And it's the same timelines as what you would do for a fee-for-service denial. So within 4 days, explain the Department of Administrative Law state fair hearing rights and offer assistance. Within 20 days, check on the appeal status, and then within 90 days, you should have a final decision. And again, enter all the information into your tracking log. And then for fee-for-service or for managed care after the internal appeal process has been exhausted, if services are denied or partially denied, or for any individual whose claim for medical assistance under the plan is not acted upon with reasonable promptness, or if the member alleges that services are not made available with reasonable promptness, the beneficiary may appeal by mailing or faxing a written request for a fair hearing to the Division of Administrative Law. And you can also fill out the form online at that website. The SC must inform the beneficiary of his or her appeal rights and provide the appeals brochure. And again, that's Appendix L. Review the brochure in its entirety, and information on appeals can be located on that LDH website. Renewals, the timelines are going to be different, but the PA tracking log is going to look the same, and ELSIS will prompt you at the appropriate time. So for fee-for-service, you're going to start your renewal 45 to 60 days prior to the end of the PA period. And for managed care services, it's going to be 20 to 60 days prior to the end of the PA period. For fee-for-service, the provider must submit the packet no less than 25 days prior to expiration of the PA for services to continue without interruption. Some services may not require a full PA packet. For MCO services, the number of days prior to expiration that the provider must submit the packet. For PA, for services to continue without interruption varies from plan to plan, and you can refer to Appendix D. Some services may not require a full PA packet. So to do a renewal, you're going to go to the current tracking log and enter the date the renewal was sent, and then you're going to click back to tracking history, bring forward a new tracking log, and choose renewal. You're going to keep the date of service request the same. You're going to enter a new choice of provider date. That's going to be the date that you started the renewal and confirmed that the beneficiary wants to stay with their current provider. And then you're going to send a referral to the provider to remind them to renew the PA. And you're going to enter that date and the date of referral to provider box on your tracking log. And then if you have not received a notice of approval from Gainwell or the MCO and the previous PA expires, that's going to trigger a referral to the PAL, and you're going to check box 3. If the beneficiary needs a schedule change, you're going to send a referral to the provider, check box 2. If the provider needs to submit additional information with the PA request and you received a PAL notice, that's going to be a referral to provider, and you're going to check box 4, which is like other, and you're going to explain what's needed. If the service is not provided at the times requested and you're not able to resolve it with the provider, that's going to be a referral to PAL, check box 6. If the service is not being provided in the amount PA'd and you're unable to resolve it with the provider, send a referral to the PAL, check box 7. And if at any time the provider is not working on behalf of the beneficiary, you're going to send a referral to the PAL, check box 8. All right, so what if the beneficiary is placed on a wait list? If at any time they're placed on a wait list for a needed service, you must document that the class member was offered alternative providers for whom there may not be a waiting list and the response received. For services that require a PA, you must send a referral to the PAL, check box 5, and there's going to be like 3 little sections of questions that you're going to fill out. So the first one's going to be if you were able to confirm the waitlist placement with the provider. The second one's going to be if they declined alternative providers. And then the third one is gonna be the date that they were placed on the wait list, and if y'all have an estimated wait time. The SC must follow up on wait list placement with the provider at least monthly to ensure that they move up the wait list. What if you are unable to locate a willing and able fee-for-service provider? If you're unable to locate a provider for a Chisholm class member, call the contact person listed on the Medicaid services chart for assistance. Make sure you contact the correct program subject matter expert when information is needed. So if it's like a durable medical equipment question, go to the durable medical equipment row of that Medicaid services chart. If the service contact person is unable to assist, call the LDH program staff line and tell them you cannot find a provider. The program staff line's hours are 8 to 4:30 with a voicemail message system for overflow and after hours calls. And then you're also always going to do a referral to the PAL, checkbox 4. If a provider cannot be located, LDH must take all reasonable and necessary steps to find a willing and able provider within 10 days. If you're unable to locate a willing and able MCO provider, so first you want to make sure that you pulled the list from the Medicaid Managed Care Program website, the provider directory, which is willing to submit a PA request. So if you've exhausted those resources, then you would want to call the MCO's member services line, which operates from 7 a.m. to 7 p.m. Monday through Friday for assistance. And then you'll complete a referral to the PAL, checkbox 4, to notify the MCO of the inability to locate a willing provider. And the MCO will take all reasonable and necessary steps to find a willing and able provider within 10 days. If the MCO is unable to locate a willing provider within 10 working days of the referral to PAL, the MCO must alert the Chisholm compliance team, and this alert will include the actions taken and reasons why the member services are not in place. The MCO is contractually responsible for ensuring that services are provided for its beneficiaries, including finding an in-home provider within 10 working days of the referral to the PAL, and the MCO may pursue a single case agreement in order to obtain a willing provider. If a fee-for-service provider is unable to find staff, so this is like after they already have a PA, you would send a referral to the PAL, call the LDH program staff line, and assist in finding another provider agency with available staff. If a provider cannot be located, LDH will take all reasonable and necessary steps to find a willing and able provider within 10 days. If you're unable to find, if an MCO provider is unable to find staff, call the MCO's member services line, send a referral to the PAL, and then the MCO.
Hey guys, we're almost finished. Can y'all settle down? There's a lot of talking going on right now.
Only got like 30 seconds.
Just a few more. Sorry.
Okay. If the MCO is unable to locate a willing provider within 10 days of the referral, they'll alert the Chisholm compliance team. They'll document the actions taken. And then again, the MCO is contractually responsible for ensuring that services are provided, including finding in-home providers within 10 working days of the referral. And the MCO may pursue a single case agreement in order to obtain a willing provider. All right, so we've made it to section 5, monitoring and follow-up activities. That includes the activities and contacts that are necessary to ensure the care plan is implemented and adequately addresses the beneficiary's needs. So during these contacts, you're going to ensure that services are being provided in accordance with the individual's care plan. Services in the care plan are adequate, and if changes in their needs or status are reflected in the care plan, and then monitoring and follow-up activities include making necessary adjustments and service arrangements with providers. A minimum of 1 face-to-face visit per quarter with each beneficiary and their guardian is required. More frequent face-to-face visits shall be required to be performed if indicated in the beneficiary's CPOC, and additional face-to-face visits may be performed if needed to obtain services. 2 quarterly visits that are not the initial or annual plan of care visit are allowed to be conducted virtually when the following conditions are met. The beneficiary family is in agreement that a virtual visit is in their best interest. The SC is in agreement. If there are any provider agencies that want or need to attend, they are in agreement. The legally responsible individual or family members living in the home are not paid caregivers. Technology is available to complete the visit with direct observation of the beneficiary in the home, and there's evidence that the requirements for the quarterly visit can be completed virtually.
And make sure that y'all are documenting that the family is requesting it virtually. Just because you don't want to go out there, that don't count. I know we did that during COVID. So it has to be documented when you code the log as a virtual visit. Otherwise, you will not get paid for that visit being done virtually.
Okay, so the virtual visit criteria, like she said, must be initiated by the beneficiary. The beneficiary and the guardian must be present. The beneficiary and the support coordinator must have a device with a camera, format capabilities, and internet services necessary to complete a virtual visit. And that includes the ability for the SC to view the beneficiary family and for them to understand how to utilize the virtual format. If the beneficiary does not have access to telehealth, the visit must be completed face-to-face. So this is not a phone call, this is a telehealth visit. Beneficiary understands HIPAA requirements for the use of a virtual format, must be able to obtain electronic signature using a HIPAA-protected platform for electronic signatures. Agencies using electronic options accept responsibility to assure compliance with all federal regulations for retention, and no more than 2 quarterly visits can be completed virtually per calendar year. So your CPOC meeting is going to be face-to-face, and then y'all should also be having at least 1 more face-to-face quarterly visit. The beneficiary and the legal guardian must always be present to conduct an initial CPOC, an annual CPOC, or a quarterly visit. The original signature page must be kept in the case record. So again, initial and annuals are going to be at the beneficiary's home. Other meetings, like your quarterly visits, can take place at the location of the beneficiary's choosing. Support coordinators are allowed to utilize telehealth in place of 2 face-to-face quarterly reassessments that are not the initial annual CPOC meeting. Through monitoring and follow-up, the SC not only determines the effectiveness of the CPOC and meeting the beneficiary's needs, but identifies when changes are needed. The purpose is to determine if supports are being delivered as planned, if they're effective and adequately meeting the beneficiary's needs, and whether they're satisfied with the supports. Every calendar month after linkage, the SC must make contact with the beneficiary to address the following. Are services being received? Are they satisfied with their services and their provider? Did you offer assistance with identified needs and problems with provider? Did you offer other services to meet their identified needs? If they want to receive any medically necessary therapies outside of the school setting, in addition to those that they receive at school, and if the beneficiary wants to receive these therapies during the school summer break, any offer of a freedom of choice, any information regarding the requirements to obtain a PA, following up on obtaining information to obtain the PA request, assisting with appeals, determination of service start date, if they're progressing with their current services, and any behavior concerns or issues. So just make sure that before y'all are making your monthly contact, that you've got like a copy of their CPOC so you know what service needs to be talking about during that monthly contact. And then as needed contact. You must make contact with the beneficiary as needed until each service included on the CPOC is fully implemented, including receipt of all PA services. Contacts may be required to assure implementation of requested services. So after you get a PA, contact the family to make sure that the services start, and then you're going to document that on your tracking log. Assist as requested with identified needs and problems with providers. Follow up on obtaining information to complete a PA request. So don't wait a whole month to contact them back. If you know that a service is requested and you do a 15-day contact and the provider's telling you that they need documentation, you should call the family, within a business day to follow up on that. Or offering to assist with an appeal. Again, if you receive a denial, you would want to contact the family within a business day to discuss the appeal. So don't wait until your next monthly contact. The SC must complete a quarterly review with the beneficiary and parent or legal guardian each quarter in order to identify the service needs and the status of those through a review of the CPOC. The service needs section of the quarterly review should document if services are received, if they're satisfied, any additional services requested, any scheduling issues, and then y'all are going to complete the CPOC quarterly review checklist and the progress summary located in ELSIS. So before you hold a quarterly meeting, you need to enter an interim CPOC, and then you need to print it out, and it's going to ask you if you want to print the quarterly review section, and you're going to say yes. And then you're going to bring that paper copy with you to your meeting. You're going to fill out the paper copy. It's going to have all your service needs listed. And then the family's going to sign off saying that they were present. And then when you get back to the office, you're going to take that paper copy and you're going to put that information into the system. So some of y'all are just doing a service log for your quarterly, and y'all are not entering the quarterly review into ELSIS, and that should not be happening. Whenever I receive an annual CPOC, I should see an annual and at minimum 3 interims with a quarterly review date there. So that's something that supervisors need to be checking for as well when y'all are reviewing annual CPOCs and you click on CPOC history. If there's no quarterlies done, that's a problem. And you shouldn't be billing for quarterlies if y'all are not entering a quarterly review into ELSIS. And then at the very bottom, it's got the virtual visit attestation. So if it's one of y'all's, if the beneficiary requested a virtual visit and your quarterly was completed virtually, you're going to say that yes, you need to do a virtual visit attestation, and then you're going to document that it met the criteria to be a virtual visit.
And if y'all didn't do a virtual, don't check the box, leave it alone.
No. And then your service log should match. So if you say that you did a virtual, it should be coded as a telehealth visit. If you said that you did it in person, it should be coded as an in-person visit. And please don't code service logs for things that y'all didn't do. If you contacted the family and they did not answer the phone, then that should be entered as a documentation
only.
Do not enter that as a 57 follow-up if you call the family and they didn't answer.
Because we will catch it, I will call y'all, and y'all will have to pay back Medicaid for that. Very, very, very important.
Yeah, so these are legal documents of things that you did and work that you did. So look at the coding and then look at the documentation.
And supervisors, when you're reviewing the service logs, you should be looking for that as well. If the body of the service log says that attempted to make contact and they called it as a 2, you should not approve that, and you should tell that SC to go void that claim, void that service log.
And don't just think that the coding covers you. The narrative progress description should support the code. So if you're saying that you made a phone call, then your service log should say, I spoke to so-and-so on the phone, and this is what we talked about.
Yes.
If you did a telehealth visit, it should say how that meeting was completed. Was it over Skype? Was it like what platform did you use? So it should support the code. If it's an in-person visit, where did you have the meeting? Like a narrative, a sentence saying, this is how I did this visit. This is who was present. This is what we talked about. These are the barriers. These are the things that I'm going to do, you know, in the future, and what my timeline is. These are the service needs that we discussed. Like, look back at the bullet points for the monthly contact. Those are the things that you should be discussing. It shouldn't just say, I called the family.
Yes, be detailed. You want a person who doesn't have the case and gets assigned the case, say y'all get an accident or maternity leave. The supervisor can go in and say, oh, I need to follow up on all these services with the participant this month. It's very, very important. Disability rights and health standards will be looking at those service logs. I don't want y'all to get deficiencies, guys. Just follow up with it. Yeah, Jamie.
But if you fill out all of that in the quarterly review, like you're talking about the services in there.
Yep.
There's a box that you could put all of that information. It's okay if it's captured there.
Yes.
It just needs to be captured on either one.
Right, yeah. So if you're doing a quarterly, you would have your your quarterly review and ELSIS, and that interim CPOC, and then in that notes box, that can be your narrative. And then on your service log, you can say refer to quarterly review and the date. You don't have to do it both places for that. Yes.
I just want to follow up on what you said about if you didn't get the period, you want to document it as documentation only, because I sometimes put telephone, because I attempted to call them, and I put 74 or service phone, and I put that I attempted to call them.
Yeah.
Yeah, if you put 74, that's fine.
Yeah.
But you can't have a 55 or 57 because that's what is pulled for your billing.
Okay.
Okay? But yeah, if you have service note and like documentation note or a type of contact and it says attempted to make a contact, no answer, then you're not going to you're not going to be billed for that. That's not going to count as your contact and paid and being fraud.
And then also, if y'all speak to anybody at the MCO or the PAL, try to get their name. That just helps. Like, if y'all have a complaint about the MCO, it really helps if I know who exactly you spoke to, or if you're transferred around to a few different departments or people, try to at least, like, document their first name and when that phone call was made. Anything else? Documentation?
Keep going.
Okay. If any complaints against...
We're good on this room.
Okay, if any complaints against SCs or Medicaid fee-for-service providers are detected at a quarterly, give the family the complaint form. If they have a complaint against their MCO or an MCO provider, give them the managed care complaint form, and then they can also call the managed care program assistance line or email healthy@la.gov. If you detect dissatisfaction with a service provider, it's your responsibility to assist in resolving the problem. If the issue cannot be resolved, send a referral to the PAL. Changes should be made to the typical weekly schedule as needed. If it's not documented for compliance purposes, it's as if it did not happen. Documentation proves that Chisholm protocols and procedures were followed. The service log will provide a narrative of activities. So each activity in contact with the provider, the beneficiary, and the PAL should be documented using a separate service log. So again, anytime you contact the provider, the MCO, me, Tracy, the LDH program staff line, anyone at the PAL, document that. These entries must be up to date, as SRI and or health standards may request to review this information in order to verify services and PA information. This is what the service logs look like. And then again, we talked about this earlier, print out a copy of the CPOC before your meeting, have everybody sign it. And then again, that just documents that, like, who was present at your meeting. So if I have any questions in the service log, I can request a copy of the signature page, and that should back up who was at your meeting. And whenever I say signature, I'm looking for like a hard, wet signature, not an electronic signature. If you're doing one of your virtual quarterly visits, y'all do have to have that electronic signature and an ability to do that. If at any time a participant or family says they want to view or sign a plan of care in person, this must be accommodated. So again, the virtual visits are only if the beneficiary requests it, and no verbal signatures are allowed. Signatures are required to document who was present, the date the meeting was held, that all service needs were reviewed, that you went over all required information, that the participant or guardian agrees with the plan, you agree with the SC statement, and then the SC supervisor agrees if they're submitting a CPOC. The quarterly report is always due the 5th of the month following the end of the quarter. You're going to use Appendix W1. It's like kind of your checklist for everything that needs to be included, a printout of the quarterly report from ELSIS, reviewed and signed, the quarterly report of revised CPOCs with a printout of the service needs changes report, record reviews for each PA not issued within 60 days and each gap in authorization period. A separate record review is required for each beneficiary and each service need. Explanation of any beneficiaries without a choice of provider. And then if y'all had any new hires that quarter, documentation of their EPSDT training using the training log.
Kim. Jamie, go ahead.
For the verbal consent, is that just like verbal consent obtained from Susan Mom? That's like the format you want?
No, so,
Time or no? What do you mean? I mean,
so for the virtual visits, y'all should have a HIPAA compliant electronic.
Like DocuSign, Adobe.
So if y'all are doing virtual visits, y'all are responsible for having the technology available to
they
obtain.
still have to sign it.
Yes.
Yes.
And then if it's an in-person meeting, do not use your electronic signature. I want you to have a printout of the CPOC and I want it signed with a pen. So that I know that that meeting was held in person and I know that the beneficiary and the legal guardian were present. Okay, so before the end of the quarter, you want to make sure that all of your PA tracking is completed, all your service logs are entered, all your CPOCs are updated so that report can be generated accurately. It's the responsibility of the agency to identify beneficiaries with a PA not issued within 60 days or with a gap. As part of that identification, the agency must review all documentation prior to the end of each quarter.
And one thing I want to say about the quarter reports, it's always due at the 5th at the end of the quarter. Y'all need to plan accordingly to get that quarter report turned in timely to Kim, because we have, LDH has to turn that into disability rights within a time frame. So if y'all have any issues, email Kim and CC me, because I need to make that aware so I can make our legal team aware of that. So plan accordingly. It's always due the 5th. Whether Saturday is the 5th, then you turn it in on the 4th. It has to be done prior to that 5th.
And even though July 5th is right around July 4th holiday, and January 5th is right around New Year's and Christmas, it's still due that day. Okay, and then when y'all are doing the record reviews for the PAs not issued within 60 days, or for gaps in authorization period, if we said that if ELSIS said that there was a gap and there is no gap, you would just document that on your printout of the quarterly report, and then you can remove it from the report. And if it was due to the family choice, then you're just going to fill out page 1 of that record review. And then the EPSDT specialist, if they are not the support coordinator assigned to that case, they need to complete the record review. And if the support coordinator involved in that particular case is the EPSDT specialist, then their supervisor or the on-site program manager is to complete the record review. Either the number of trackings without a choice of provider must be 0, or documentation and explanation must be attached for each beneficiary and each service need without a choice of provider. SRI and the LDH attorney will review the information to assure that beneficiaries are receiving the services they need and that assistance they need to access services. SRI will request supporting documentation and information from the SCAs as needed. All right, and we talked about the 16 hours of orientation training, the 20 hours of annual training. So following this training, y'all will need to submit documentation that we completed the training. And then again, with your quarterly report, you'll send me documentation of any new hires. The on-site program manager is responsible for assuring compliance with all program requirements, and the EPSDT specialist is to monitor that all EPSDT requirements are being met. So those 2 people at y'all's agency should be reviewing ELSIS reports at least twice a week and addressing deficiencies at that time. The purpose of support coordination is to coordinate all services and to ensure the beneficiary receives the services that he or she needs. If at any time a provider is not actively working on behalf of the beneficiary, contact the PAL, contact SRI if you have questions regarding support coordination, and contact state office for any policy questions. And then CMS put out a best practices for adhering to EPSDT requirements. Worth the read.
We're almost done.
Yeah, promise. The EPSDT mandate represents a critical part of the Medicaid program that is designed to ensure eligible children have access to essential medical, dental, behavioral health, and developmental services from an early age. As Medicaid has grown more complex, navigating access to these services has become more difficult, with coordination and assistance ever more important to access care. The collective effort and shared commitment of CMS, state Medicaid agencies, healthcare providers, and caregivers is essential in advancing the coverage goal of EPSDT, the right care to the right child at the right time and the right setting to help ensure children in Medicaid have the opportunity to reach their full health potential. All right, and then if y'all have any additional questions, feel free to email them to me and I'll add them to our questions and answers. That's my contact info, and then I've got Tracy's contact info there. And sorry we ran a little over.
Yep, sorry guys, we ran over, but that's it. We're good, thank y'all.
Monroe.